and good evening everyone else. Okay, so we had started with liver yesterday. In liver, I had showed you the normal anatomy. Then, yes, Yutika, Pooja, Yankila, all of you, good evening. Yes. Okay, so I had finished liver. Yes, I had started with liver yesterday. Yes, Adesh, good evening. I had started with liver yesterday, and in liver, I had just given the introduction. So I had finished with the normal anatomy of liver, the tests that you do in cases of liver disease, and then we had done cirrhosis of liver. Okay, so now I'll start with, okay, Yutika, Yutika, I'll be doing liver with that little bit of gallbladder, with the liver, gallbladder and pancreas. Then I have to do kidney. Then I have to do cardiovascular system and blood vessels. Then I have to do respiratory system. Then I have to do FGS, MGS and breast. That is your reproductive pathology. And then from bones and joints also I will cover some parts. So these are the topics that are left. And yesterday also I told you at least I will take 8 lectures more. Not included, today's lecture not included. Okay, so now let us start with the other entities. Okay, now in liver I will be covering alcoholic liver disease, very important. Before that, let me write down a few lines on Reye's syndrome. So very important, Reye's syndrome, R-E-Y-E, Reye's syndrome. Okay, so Reye's syndrome. Okay, now Reye's syndrome, this is usually seen in children. Okay, so it is rare, and the child has hepatic encephalopathy. Okay, so this is rare syndrome. Number one, it is rare. And here now, what does the child present with? It is childhood hepatic encephalopathy. Hepatic encephalopathy. So the child presents with hepatic encephalopathy, which often leads to death, leads to death. Okay, so that is hepatic encephalopathy leading to death. Okay, now what is the cause and what are the features of Reye's syndrome? Okay, now who are the children who have this Reye's syndrome? Now this is, child develops viral infection. So viral infection, so this is seen in children who have viral infection, like influenza infection. So the child gets viral infection, for which aspirin is given, aspirin has been given. So who are the children who end up with this Reye's syndrome? So the child gets viral infection, and that is now you are treating that with aspirin. That child may end up with hepatic encephalopathy. And you know what happens? Why hepatic encephalopathy happens? The aspirin metabolites. When aspirin get metabolized in the child's body, aspirin metabolites, they decrease fatty acid oxidation in the mitochondria by inhibiting the mitochondrial enzymes. So what do aspirin metabolites do? These aspirin metabolites, inhibit beta oxidation of fatty acids. Beta oxidation of fatty acids in mitochondria. So beta oxidation of fatty acids happens in the mitochondria. So aspirin inhibits this, aspirin metabolites, they inhibit this beta oxidation of fatty acids by inhibiting enzymes. So these aspirin metabolites, they inhibit the enzymes that are involved in beta oxidation of fatty acids in the mitochondria. So once this happens, now this leads to fatty liver. So the child ends up with fatty liver, and So you see there are mitochondrial abnormalities. So what are the findings that we have? So findings are, number one, there are mitochondrial abnormalities, as we have already seen. So there are mitochondrial abnormalities, one. So what is the mitochondrial abnormality? Mitochondrial enzymes involved in beta oxidation of fatty acids have been inhibited by aspirin metabolites. Okay, second, what do you see? You see fatty change in the liver. Fatty change in liver. Okay, now, you know, when we read about fatty change, there is something called microvesicular fatty change and macrovesicular fatty change. So we'll see a picture. Okay, now, you know, what is fatty liver? Fatty liver means accumulation of triglycerides in the liver. Okay, and during routine processing of the tissue, the triglycerides are lost. So fat is seen as, in fatty liver, in the hepatocytes, fats or triglycerides are seen as clear vacuoles. Okay, now look at the size of the vacuoles. If the size of the vacuoles is very small, so if say this is the hepatocyte here, this is the nucleus of the hepatocyte. In the cytoplasm of the hepatocyte, now you see multiple tiny fat vacuoles. This is called microvesicular steatosis. So in case of Reese syndrome, we see microvesicular steatosis. So we see microvesicular steatosis. Okay, and then the child has hypoglycemia, and now the child develops features of encephalopathy. So the child has vomiting. So there is vomiting, liver is enlarged, there is hepatomegaly, liver becomes enlarged, there is hepatomegaly, and the child goes into coma. So this is what we see in Reed syndrome. So basically the defect lies in the mitochondria. The defect is that aspirin metabolites, they inhibit the fatty beta oxidation of fatty acids going on in the mitochondria by inhibiting the enzymes. As a result, in the hepatocytes, because of this mitochondrial defect produced by aspirin metabolites, there is microvesicular steatosis, that is tiny vacuoles of fat accumulate in the hepatocytes. Also there is hypoglycemia, vomiting, hepatomegaly, and coma. So we have to avoid aspirin. So the treatment, so aspirin should be avoided in children with viral infections. Aspirin should be avoided. Okay. So now this is about Reese syndrome. Okay. Now let us come to very important alcoholic liver disease. Alcoholic liver disease. Okay. Now, you know, alcohol is bad. Alcohol or ethanol, that is ethanol. Ethanol damages the liver. Okay, how does it damage the liver? Number one, ethanol, you know, it leads to accumulation of lipids in the hepatocytes, or in other words, ethanol or alcohol causes fatty liver, fatty change in the liver. So ethanol promotes lipid accumulation. Lipid accumulation. Darwaza band kar do. So number one, ethanol promotes lipid accumulation in the liver. Number two, ethanol causes liver cell injury. A metabolite of ethanol called, when ethanol is metabolite, acetaldehyde is produced. So acetaldehyde is toxic to hepatocytes. So acetaldehyde is toxic to hepatocytes. So ethanol metabolism produces acetaldehyde, which is toxic to hepatocytes. Third, you know, when again ethanol is metabolized, there is oxidative stress is produced, which again damages the liver. So liver cell injury due to increased oxidative stress. So liver is also injured due to oxidative stress. And last is, you know, an alcoholic, a person who consumes alcohol, his intake of vitamins also becomes less. So decreased intake of vitamins. Vitamins also, all these factors cause injury to the liver. So main is that metabolite of alcohol metabolism called acetaldehyde, that is toxic to the hepatocytes. Then free radicals, when ethanol is metabolized in the liver, free radicals are generated which impose oxidative stress, and this oxidative stress again damages the hepatocytes, and then liver causes fatty change. Okay, now let us see how liver causes fatty change. So it causes lipid accumulation, or it causes what you call as fatty change. Okay, now how does liver do this? So if you see ethanol, when ethanol enters when a person drinks alcohol, this ethanol is first converted to acetaldehyde, and the enzyme that converts ethanol to acetaldehyde is alcohol dehydrogenase. Alcohol dehydrogenase. And when ethanol is converted to acetaldehyde, in this process, NAD is converted to NADH. NAD gets converted to NADH. Okay, second, now this acetaldehyde, as we saw, this acetaldehyde, it is toxic to hepatocytes. It is toxic to hepatocytes. Okay, then this acetaldehyde is further converted to acetic acid in the mitochondria. It's converted to acetic acid in mitochondria. The first step, that is ethanol getting converted to acetaldehyde in presence of alcohol dehydrogenase, this happens in the cytoplasm. And then second, this acetaldehyde is converted to acetic acid in the mitochondria, and this happens in presence of the enzyme called aldehyde dehydrogenase. Aldehyde dehydrogenase. This happens in presence of aldehyde dehydrogenase. So therefore, if you see, this NADs get converted to NADH. Therefore, NAD is reduced. So thus there are decreased NAD levels in cytoplasm. So what do you conclude? So this first step is happening in the cytoplasm. So NAD levels of cytoplasm reduce. So NAD levels of cytoplasm reduced, and NAD plays an important role in fatty acid oxidation. So what is the role of NAD? NAD, it plays a role in fatty acid oxidation. So NAD plays an important role in fatty acid oxidation. So now when NAD levels in the cytoplasm reduce, this decreases fatty acid oxidation. So since NAD is not available, fatty acid oxidation decreases, and this leads to accumulation of fat in the liver. Accumulation of fat in hepatocytes. So as a result, now in the hepatocyte, fat starts to accumulate. This is what we call as, so this is the pathogenesis of alcohol-induced liver injury. So once again, if you see alcoholic liver disease, it is ethanol or alcohol. Number one, it causes fatty liver. Okay, and that fat accumulates inside the hepatocytes. It causes fatty change of lipid accumulation in the liver, which is going to damage the hepatocytes. Second, when alcohol is metabolized or ethanol is metabolized, acetaldehyde is produced, which is toxic to the hepatocytes. Also, in all this process, when alcohol gets metabolized, free radicals are generated, which free radicals impose oxidative stress and cause damage to the hepatocytes. And alcoholic, also in an alcoholic, the vitamin intake also decreases, and in many vitamins, especially vitamins like B6, are very important because they act as cofactors in the liver. So now ethanol, first in the cytoplasm, enzyme alcohol dehydrogenase converts ethanol to acetaldehyde, and in this process NAD is getting converted to NADH. So the cytoplasmic level of NAD reduces. Also then this acetaldehyde by enzyme aldehyde dehydrogenase is converted to acetic acid, which happens in the mitochondria. So now since NAD levels in the cytoplasm are reduced, this will cause decreased fatty acid oxidation and fat will accumulate in the hepatocytes. Okay, so fat accumulates causing fatty change. Okay, now if you look at alcoholic liver disease, there are three stages. First stage is hepatic steatosis. Hepatic steatosis. Steatosis means fatty liver. So fatty liver. So when a person drinks alcohol, first he develops fatty liver. Fatty liver, or what we call hepatic steatosis, which is reversible. This is followed by alcoholic hepatitis. Alcoholic hepatitis. So this is followed by alcoholic hepatitis, and alcoholic hepatitis can progress to alcoholic cirrhosis. Alcoholic hepatitis can progress to alcoholic cirrhosis. So first steatosis, then hepatitis, and then cirrhosis. And once a patient develops cirrhosis, cirrhosis is associated with increased risk of developing hepatocellular carcinoma. So cirrhosis, alcoholic cirrhosis is associated with increased risk of developing hepatocellular carcinoma. Okay, now first step is hepatic steatosis. So what is first? First is hepatic steatosis. Steatosis, or what you call as fatty liver. Okay, now this is reversible. Reversible if alcohol is stopped, if alcohol consumption is stopped. So the first step, that is hepatic steatosis, is reversible if the alcohol consumption is stopped. And second, now what type of steatosis is this? This is macrovesicular steatosis. Macrovesicular. So this is macrovesicular steatosis. That is, if you look at the hepatocyte, this is the nucleus of the hepatocyte. In the hepatocyte, you will find a single large vacuole of fat, a single large vacuole, big size vacuole of fat. This is called macrovesicular steatosis. Okay. Second, if alcohol consumption is not stopped, then patient progresses to alcoholic hepatitis. Okay, now for alcoholic hepatitis to develop, sustained long-term consumption of alcohol is needed. So this requires sustained long-term consumption. So sustained long-term alcohol consumption. So sustained long-term alcohol consumption will produce alcoholic hepatitis. Okay, now the term is hepatitis. That means we'll see inflammatory cells also in the liver. So first, what do we see in alcoholic hepatitis? Number one, the alcohol damages the hepatocytes. Hepatocytes swell up. So first we see ballooning degeneration. Ballooning degeneration of hepatocytes. Ballooning degeneration of hepatocytes. So what is ballooning degeneration? Swelling of the hepatocytes. So hepatocytes become swollen. Second, necrosis of, so they start dying. Necrosis of hepatocytes. So hepatocytes start to die. Okay, now when hepatocytes die, that area is filled with neutrophils. So hepatocyte necrosis with neutrophilic infiltration. Neutrophilic infiltration. So if a hepatocyte dies, that dead hepatocyte is replaced by neutrophils in that area. So necrosis of hepatocytes with neutrophilic infiltration. And third, we see Mallory bodies. Mallory bodies in hepatocytes. So what are Mallory bodies? They are pink colored bodies inside the cytoplasm of hepatocytes. So they are intracytoplasmic. What is their color? They are pink colored. Intracytoplasmic eosinophilic. Eosinophilic means pink. So intracytoplasmic eosinophilic inclusions in hepatocytes. So intracytoplasmic eosinophilic inclusions at the hepatocytes. And very important, you are asked sometimes, what are they composed of? They are composed of, alcohol has damaged the keratin filaments, cytokeratin filaments. Cytokeratin is an intermediate filament found in all our cells. So hepatocytes also have cytokeratin filaments. Now they are found in the cytoplasm. Alcohol damages these cytokeratin filaments, and these damaged cytokeratin filaments, they form Mallory bodies. So what are Mallory bodies? They are damaged cytokeratin filaments. So alcohol has damaged the cytokeratin filaments, and these damaged cytokeratin filaments now form pink colored inclusions in the hepatocytes. So this is alcoholic hepatitis. Okay, now in alcoholic hepatitis, if you look at liver enzymes, we already know in alcoholic liver disease, aspartate aminotransferase, AST, is elevated more than ALT. So AST is elevated more than ALT. How much more than ALT? Usually more than 2:1. So more than 2:1. And in addition, also there is raised gamma glutamyl transpeptidase, raised GGTP. So we did this yesterday. So in alcoholic liver disease, AST is raised more than ALT, more than 2 times. So both are raised, but AST will be raised more than 2 times ALT, and gamma glutamyl transpeptidase is also raised. Okay, now last stage is if person does not stop alcohol consumption, last stage is alcoholic cirrhosis. Alcoholic cirrhosis. So last stage is now the patient develops cirrhosis of liver, alcoholic cirrhosis. Another name for alcoholic cirrhosis is it's also called Linacek cirrhosis, L-A-E-N-N-E-C, Linacek cirrhosis. Okay, so it's called Linacek cirrhosis. Now this is the final and irreversible stage. Irreversible stage. Okay, the previous stage, that is alcoholic hepatitis, this is reversible to some extent. This is reversible. This is reversible till fibrosis appears. Once fibrosis appears, then it is not reversible. So alcoholic hepatitis is reversible till no fibrosis is there in the liver. Once fibrosis starts, then it will go towards cirrhosis. And cirrhosis definitely is the final and irreversible stage. Okay, now, yesterday I told you nodules in cirrhosis, nodules are formed on the liver, and these nodules can be less than 3 millimeter or more than 3 millimeter in size. So less than 3 millimeter size nodules are called micronodular cirrhosis. So in alcoholic cirrhosis, this is micronodular cirrhosis. Okay, now in cirrhosis, due to any cause, the liver becomes shrunken and develops nodules on the surface. So alcoholic also is micronodular. It is micronodular cirrhosis. So there are micronodules on the liver, plus the liver is irregularly shrunken with hobnail appearance. So liver is irregularly shrunken. And these nodules stand out like hobnails. So liver is irregularly shrunken with hobnail appearance. So liver is irregularly shrunken with hobnail appearance. Okay, now if you see under the microscope this cirrhosis, fibrosis starts in the liver. Okay, now where does the fibrous tissue first get deposited? And if you remember, yesterday I told you in the space of Deci there is a cell called Ito cell. It is this Ito cell which is going to lay down the fibrous tissue and cause cirrhosis. Okay, now first, where is the fibrous tissue getting deposited? First, the deposition, where does it start first? The fibrous tissue or fibrosis, or we use another term called sclerosis. Sclerosis first starts around the central vein. Central vein is in the center of the lobule. So around the central vein, sclerosis first begins. So sclerosis first starts around the central vein. So sclerosis first starts around the central vein. So in the center of the lobule is a central vein. So it first starts in the around the central vein, and then it spreads to the periportal areas. So then it spreads, then it goes to perisinusoidal area. So it starts around the central vein and then spreads. This gives it looks like a chicken wire fence pattern. So then after this, so sclerosis first starts around the central vein, and then perisinusoidal scarring. Perisinusoidal. This is followed by perisinusoidal sclerosis. So around the sinusoids also fibrosis will start. So fibrous tissue will start getting deposited, and this produces a characteristic chicken wire fence pattern. Chicken wire fence pattern. So this is called chicken wire fence pattern. And clinical features, now when the patient goes, yes, Sri Devi, Ito cell has two functions. Number one, Ito cell is a storehouse of vitamin A. And second, Ito cell lays down fibrous tissue when cirrhosis happens. Okay, clinical manifestations, now when the patient ends up with cirrhosis, he will have all the features of, all the features of cirrhosis. So clinical features of chronic liver disease. He will have all the clinical features of chronic liver disease like jaundice, hypoalbuminemia, ascites, all those features which we have already discussed, they will be seen. Okay, if you look at peripheral smear of a patient of alcoholic liver disease, on peripheral smear, one of the cause, you see macrocytosis. I have already told you. So there is macrocytes are seen on the PS. So alcohol causes macrocyte formation. So peripheral smear shows macrocyte formation. So this is about alcoholic liver disease. Okay, now let us look at the picture. Okay, first, this is alcoholic liver disease. Look at this healthy liver and then cirrhotic liver. Both are drawn. Okay, and what type of cirrhosis is it? It is micronodular cirrhosis, less than 3 millimeter size nodules on the surface of liver, and these nodules, there are large areas of fibrosis or scarring, and these tiny nodules stand up like hobnails. Okay, one. Two, now let us see this picture. Okay, so now first look at this. The arrow is showing this is a hepatocyte. In the cytoplasm of the hepatocyte, you are seeing this pink colored structure. The arrow is showing this structure. This is a memory body. So what is this? This is memory body. Okay, now look at these. So this is a memory body. Okay, second look at these. So many hepatocytes are there in this picture. Second look at this. Second, so the arrow is showing memory body in the cytoplasm of the hepatocyte. Okay, now look at this area. Look at this area. What is this? This is now neutrophil. All these dots, numerous dots that you are seeing, these are inflammatory cells. So this is where a hepatocyte has undergone necrosis, and neutrophils. This is neutrophilic infiltration. Neutrophilic infiltration, which is seen in alcoholic hepatitis. Okay, second, look at this picture. Now in this picture, arrowheads are there. Look at the arrowheads. All look at the hepatocytes. They are all swollen. So what do you see? This is all hydropic change or ballooning degeneration. So swelling. So all these is swelling of the hepatocytes. They have this clear cytoplasm. All these are swelling of the hepatocytes. So you are seeing swelling of the hepatocytes. And here also, again, I have circled in green. Another thing that you see in this picture is you are seeing again neutrophilic infiltration. So in both the pictures I have circled neutrophilic infiltration. Okay, now look at this. This is fatty liver, slide of fatty liver disease associated with chronic alcohol use. Fatty liver disease associated with chronic alcohol use. Now you can see these this is macrovesicular steatosis. One, microvesicular steatosis. Okay, second important point to be noted is, now this is the central vein. What you see in blue color here, now this is not normal stain. This is a stain called Mason's trichrome. What is this? This is a stain called Mason trichrome. And this is a stain for collagen. This is a stain for collagen. Yes, Sridevi, hydropic ballooning degeneration or hydropic change is reversible. So many hepatocytes are showing ballooning degeneration, or they are showing hydropic change, and then some hepatocytes are also undergoing necrosis and dying, which becomes irreversible, and their place is filled with neutrophilic infiltrate. Okay, now if you see this picture, which stain is this picture showing? This is Mason's trichrome stain. In this stain, you can see blue areas. What are these blue areas? This is chicken fence, what you call as chicken wire fence pattern. So you in the center, this is central vein. Around from the central vein, you can see a number of blue colored lines coming out. Okay, all these blue colored lines are fibrous tissue. So fibrosis is happening around the central vein, and then it is going to the perisinusoidal areas. So perisinusoidal sclerosis is also happening. So this is Mason's trichrome is showing chicken wire fence appearance. So this is chicken wire fence appearance which we see here. Okay, so this is about alcoholic liver disease. Okay, after alcoholic liver disease, people who don't take alcohol, they can also end up with all these features. So those who don't take alcohol. So there is something called as non-alcoholic fatty liver disease. So next is non-alcoholic fatty liver disease. So next is something called non-alcoholic fatty liver disease. Okay, non-alcoholic fatty liver disease is fatty changes in the liver in people who don't use alcohol. So fatty changes in liver in patients who don't consume, who have no history of alcohol consumption. So they don't consume alcohol, still they are having fatty changes in the liver. It is not liquefactive necrosis. Alcohol neutrophilic. No, it is not liquefactive necrosis. It is coagulative necrosis. Actually, in liver, okay, in liver liquefactive, this is not, it's not liquefactive necrosis. It's not liquefactive necrosis. Okay, so non-alcoholic fatty liver disease. So in non-alcoholic fatty liver disease, patient can have stages, can be, again, first there can be steatosis. Second, steatosis can progress to steatohepatitis. So they first have fatty liver, then they have inflammation also, that is steatohepatitis, which can again progress to cirrhosis. So just like alcoholic liver disease, where you have hepatic steatosis, then you have alcoholic hepatitis, and then you have alcoholic cirrhosis. Here also they develop steatosis of fatty chains, then that progresses to steatohepatitis, which can progress to cirrhosis. And you know, associations now, association of non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is constantly or consistently associated with metabolic syndrome and insulin resistance. So it is consistently associated with metabolic syndrome. It is consistently associated with metabolic syndrome and insulin resistance. Insulin resistance. So consistently associated with metabolic syndrome and insulin resistance. Other associations, very important associations, other associations are type 2 diabetes mellitus. So these patients can have type 2 diabetes to obesity. Obesity, usually they have central obesity. So type 2 diabetes, central obesity, then dyslipidemias like they can have, they have what you call as hypertriglyceridemia. They have hypertriglyceridemia, then decreased HDL cholesterol and increased LDL cholesterol. So these are dyslipidemia. So they have dyslipidemias, and third, they also have hypertension. So they also have hypertension. Okay, now if you see in this condition, if you look at the liver enzymes, you know, ALT is more than AST. In alcoholic liver disease, AST was more than ALT and the ratio was more than 2:1. Here ALT is more than AST. So ALT is more than AST. Okay, so ALT is more than, so here ALT is more than AST. Okay, and ultimately these people can also end up with cirrhosis, which may, and associated with increased risk of developing, hepatocellular carcinoma. Okay, so hepatocellular carcinoma. So this is about non-alcoholic fatty liver disease. Okay, Ayush, you have asked me to give, okay, fibrosis starts around the central vein. Okay, now fibrosis. Okay, so in case of this alcoholic cirrhosis means fibrous tissue comes in the liver. Fibrous tissue first comes around the central vein. It starts getting deposited around the central veins. And then, you know, from the central vein, you have cords of hepatocytes. Between the hepatocytes, you have sinusoids. Then after the central vein, it will go into the perisinusoidal areas. So it will go along these sinusoids. So perisinusoidal means along the sinusoids. And this produces what we call as chicken wire fence pattern. So if you see the picture once again, so this produces, so this is this blue lines, all these blue colored lines which you are seeing around the central vein. You can see these areas of fibrosis, fibrous threads around, and then you can see they are going down as well. So they are going down as well. So this produces chicken wire fence appearance. So this is called chicken wire fence appearance. Okay, so the second is non-alcoholic fatty liver disease. Okay, now let us come to the next entity. Yes, the term fibrosis and sclerosis are same. Fibrosis and sclerosis are same. Okay, coming to the next now, let us look at tumors of liver. Tumors of liver. So next entity, very important entity, let us come to tumors of liver. Okay, in tumors of liver, we have benign tumors and malignant tumors. Malignant tumors. Okay. So now in benign tumors of liver, we will see two tumors, that is cavernous hemangioma. Cavernous hemangioma. And second benign tumor that we will see will be hepatic adenoma. Hepatic adenoma. Okay. In malignant tumors of the liver, in malignant tumors, remember, in the liver, metastasis is more common than primary liver tumor. So metastasis, so in the liver, malignancies are metastasis. One, metastasis. Two, hepatocellular carcinoma. That is liver cancer, hepatocellular carcinoma. Another important liver tumor about which you should know one or two lines is angiosarcoma. Angiosarcoma of the liver. Angiosarcoma of the liver. Okay. Now, most common liver tumor. Okay. So these are the tumors. Okay. First, let us see few lines on benign tumors. In benign, first is a cavernous hemangioma. Hemangioma. Now, cavernous hemangioma is the most common benign tumor of liver. Most common benign tumor. Tumor of liver is a cavernous hemangioma. Age group usually between 30 to 50 years of age. Hemangioma is a tumor of blood vessels. Yes. Absolutely. Biopsy is absolutely contraindicated, because if you do a biopsy, there is a big risk of causing lot of bleeding. So as Sri Devi has written, biopsy contraindicated. Contraindicated due to risk of bleeding. Risk of bleeding. So this patient may develop, they are likely to bleed profusely. Okay, second is important hepatic adenoma. Adenoma, this is a benign tumor of hepatocytes, adenoma. So adenoma is not very common. So it is a rare tumor. It is a benign tumor. Very important. Your questions are based on, adenomas develop in females taking oral contraceptive, or it is also associated with anabolic steroids. So oral contraceptives and anabolic steroids. So associated with use of oral contraceptives and anabolic steroids. And if they may regress on their own also. And sometimes these hepatic adenomas, they may rupture and the patient may have abdominal pain and shock. So they may regress spontaneously. Or they may complication is they may rupture. These tumors may rupture and this may lead to shock. So they may rupture leading to shock. Okay. So these are benign tumors. Now looking at the malignant tumors. Okay. Now in malignant tumors, in malignant tumors which I have drawn here, I told you metastasis is more common than hepatocellular carcinoma or the primary liver cancer. Okay. So metastasis are more common. Metastasis more common than primary liver carcinoma, liver cancer. So metastasis is more common. Which is the primary liver cancer? Hepatocellular carcinoma. So metastasis is more common than primary liver cancer. And from where do mets come in the liver? Metastasis come in the liver. So where is the primary tumor? Primary tumor is usually in the GI tract or breast or lung. So for metastasis, the primary is in GIT. For example, colonic cancer can produce metastasis in the liver. Pancreatic cancer can produce metastasis in the liver or other sites also. So primary is usually in the GI tract, breast. So the breast cancer can metastasize. So GI cancers can metastasize to liver, breast cancer and lung cancer. They can metastasize to the liver. So this is metastasis. So this is in malignant tumors, first entity is metastasis. Metastasis. So first is metastasis. So metastasis are more common than primary liver carcinoma, that is hepatocellular carcinoma, and metastasis can metastatic deposits in the liver can be due to GI cancers can produce, breast or lung. And you know, metastatic deposits, if you look at the liver, metastatic deposits will always be multiple. Primary, if there is hepatocellular carcinoma, it is usually unifocal or a single mass, whereas metastases are multiple with central umbilication. So on examination, if you see metastases are, these are multiple deposits with central umbilication. Central umbilication means you have a deposit, you have a nodule, so you have multiple deposits or multiple nodules, and these nodules in their center, they show umbilication. You know, umbilicus goes inside, so their center dips inside, because in the central portion the cells undergo necrosis, so they sort of go inside. So the nodule, so you will have nodules like this with central umbilication here. The central portion undergoes necrosis. Okay, so these are metastases in the liver. Second liver tumor is angiosarcoma. Angiosarcoma. So then after that we will see hepatocellular carcinoma. Okay, angiosarcoma, it is a malignant tumor that arises from blood vessels, from endothelial cells of blood vessels. Yes, yes, Adesh, colon, stomach and pancreas, absolutely. Okay, so angiosarcoma, it is a malignant tumor that arises from endothelial cells of blood vessels. Endothelial cells of blood vessels. So angiosarcoma is a malignant tumor that arises from endothelial cells of blood vessel. Very important. Angiosarcoma is associated with, if you remember your neoplasia chapter, I had told you, I had given you a list of carcinogens. So the two important carcinogens associated with angiosarcoma are arsenic and vinyl chloride. So it is associated with arsenic and vinyl chloride. Okay, arsenic and vinyl chloride. Okay, now let us come to most common primary liver cancer, that is hepatocellular carcinoma. Hepatocellular carcinoma, you know, it is also called hepatoma. Another name is hepatoma, but you know, hepatoma makes it sound like a benign tumor. You know, benign tumors have a suffix "oma," but hepatoma actually is the other name for hepatocellular carcinoma, which is the malignant tumor of the liver. Okay, so that is hepatocellular carcinoma. So this is the most common. So hepatocellular carcinoma is the most common primary liver cancer, liver malignancy. So most common primary liver. So in liver, if you look at the malignancies, which is more common, metastasis is more common than hepatocellular carcinoma. But if you look at the primary liver tumors, out of primary liver tumors, most common primary liver malignancy is hepatocellular carcinoma. Okay, now etiology. Etiological factors for hepatocellular carcinoma. Etiology, number one, viral infections. Viral infections of the liver can lead to hepatocellular carcinoma, like hepatitis B virus, very important, hepatitis C. Second, very important, toxins can damage the liver and produce hepatocellular carcinoma. Very important is aflatoxin. Very important is aflatoxin. You know, aflatoxin comes from fungus aspergillus. And you know, this aflatoxin is produced by this aspergillus. And yes, Adesh, you are absolutely right. Colon, stomach, pancreas, that is GIT. Okay, and after GIT, you have breast and lung going into producing metastasis to the liver. So very important, aflatoxin. Aflatoxin is a toxin produced by fungus aspergillus, and you know, this aflatoxin is produced. Aspergillus grows in stored grains. When grains are kept stored, you know, in godowns, this fungus can grow in the grains and produce aflatoxin, which causes hepatocellular carcinoma. So that is toxins. Then the second important toxin is alcohol. very important toxin which leads to hepatocellular carcinoma is alcohol. Then third, non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease can also lead to this. Then fourth is, so non-alcoholic fatty liver disease. Then metabolic diseases. Metabolic diseases of liver can also predispose to hepatocellular carcinoma. Metabolic diseases are alpha-1 antitrypsin deficiency, Wilson's disease. We will be seeing all these: Wilson's disease and hemochromatosis. Hemochromatosis. All can predispose to hepatocellular carcinoma. So metabolic diseases of liver. Then autoimmune hepatitis. Autoimmune hepatitis. So autoimmune hepatitis can also predispose to, autoimmune hepatitis can also lead to fatty liver. Can also lead to hepatocellular carcinoma. And then patients with metabolic syndrome. Metabolic syndrome. So patients with metabolic syndrome, that is obesity, we already know obesity, diabetes mellitus and non-alcoholic fatty liver disease. So we can combine them together. So metabolic syndrome are also at risk of developing hepatocellular carcinoma. Okay, hepatocellular carcinoma. Okay, now this hepatocellular carcinoma, if we see clinical, or what are the findings? Findings in a patient with hepatocellular carcinoma. Number one, patient will come with jaundice. So patient of hepatocellular carcinoma has jaundice. Two, now liver is, there is tender hepatomegaly. So liver is enlarged, there is tender hepatomegaly. So there is tender hepatomegaly. Third, they develop ascites. So liver is not functioning properly. There is a big tumor in the liver. Enough albumin is not being produced. So there is ascites. So they have ascites. Fourth, if you remember, we covered paraneoplastic syndromes. So, hepatocellular carcinomas, these tumors, they can produce erythropoietin, which leads to polycythemia. And then also anorexia and weight loss, as she has rightly written, anorexia. Of course, weight loss occurs with most of the cancer. So patient also gives history of weight loss. Spread, metastasis. So hepatocellular carcinoma, how does it spread? Though it is a cancer, but usually spreads via hematogenous route. Spreads via hematogenous route. And hematogenous route means it invades the hepatic vein. Cancer cells, they invade the hepatic vein, and these cancer cells, they invade the hepatic vein, and they can also cause hepatic vein thrombosis. Hepatic vein thrombosis is called Budd-Chiari syndrome. So they spread via hematogenous route, invade the hepatic vein, and Budd-Chiari syndrome. So Budd-Chiari, C-H-I-A-R-I, Budd-Chiari syndrome can be produced. May occur. What is Budd-Chiari? Budd-Chiari is hepatic vein thrombosis. So hepatic vein thrombosis. So patients with hepatocellular carcinoma can have thrombosis of the hepatic vein. So that is called as Budd-Chiari syndrome. Okay, then diagnosis. How do you diagnose? There is a tumor marker called alpha-fetoprotein. So increased serum alpha-fetoprotein levels. But we know serum markers should not be used as a sole means. They should not be used for screening and diagnosis. They can be used as adjuncts to diagnosis, to follow up and to monitor recurrence. They should be used. So alpha-fetoprotein levels are raised. And then how do you diagnose? You can diagnose by ultrasound or contrast CT or MRI. And of course, if you see a mass, third is biopsy. Biopsy, of course, is the gold. Biopsy is, you have to do a biopsy and make a diagnosis of hepatocellular carcinoma. So biopsy will give you the final diagnosis. Okay, now important point is there is, there is a variant of hepatocellular carcinoma. Hepatocellular carcinoma occurs in adults. There is a variant of hepatocellular carcinoma which occurs in less than 30, usually it occurs in 5th to 6th decade of life, hepatocellular carcinoma. Hepatocellular carcinoma. Yes, Adesh, we'll after this I'll talk about Budd-Chiari, and Budd-Chiari also occurs in PNH. Yes, absolutely correct. Okay, there is a variant of hepatocellular carcinoma. Hepatocellular carcinoma called, there's a variant of hepatocellular carcinoma called fibrolamellar variant. Fibrolamellar variant. Fibrolamellar variant. Now, as I told you, hepatocellular carcinoma usually occurs in 5th or 6th decade of life. Fibrolamellar variant, age is less than 35 years usually. Patient is less than 35 years of age and they present with a single hard nodule, serous nodule. So, presentation is single hard nodule in liver. Single hard nodule in the liver, and this is rare variant, accounts for 5% of hepatocellular carcinomas, and comparatively it has a better prognosis. It has a good prognosis. So it is in younger people, single hard serous hard nodule will happen and it carries a better prognosis than the usual hepatocellular carcinoma, that is the fibrolamellar variant. Okay, so this is about the tumors of the liver. So now here few lines on Budd-Chiari syndrome. Budd-Chiari syndrome. Okay, what is this Budd-Chiari syndrome? Budd-Chiari syndrome is hepatic vein, either a thrombus in the vein or the vein is getting compressed. So thrombosis or compression of hepatic vein. So in Budd-Chiari there is thrombosis or compression of hepatic vein. So hepatic vein is either thrombosed or compressed. So what will this lead to? If hepatic vein is thrombosed or compressed from the liver, venous blood cannot drain out of the liver. So venous blood will accumulate in the liver. Okay. So now when venous blood accumulates in the liver, around the central vein, there will be congestion and necrosis of hepatocytes. So this leads to centrilobular congestion. Venous blood goes out from the lobule, central vein drains out the venous blood. So now all the venous blood, since there is hepatic vein is thrombosed or compressed, blood cannot drain out, venous blood cannot go out of the liver, it accumulates in the lobules, and in the lobules it accumulates around the central vein. So there is centrilobular congestion and necrosis. So the hepatocytes around the central vein, they undergo necrosis, and there is congestive liver disease. So there is congestive liver disease. So the liver is now congested. So congestion is much more prominent around in the centrilobular areas, and there is necrosis of hepatocytes also in those areas. So clinical features, what will the patient have? Number one, hepatomegaly. So liver is markedly congested, it is enlarged. Patient has ascites. Hepatomegaly, ascites, abdominal pain. Hepatomegaly, ascites, abdominal pain. Yes, Adesh, hemorrhagic necrosis. Correct. It is hemorrhagic necrosis. Okay. So they have this and liver, there may be liver failure as well. So ultimately the liver may also fail. Okay. Now causes of Budd-Chiari. Causes of Budd-Chiari usually are hypercoagulable states where there is increased tendency to clotting of blood. So it is associated with hypercoagulable states. Okay, hypercoagulable states. There are I covered. There is something called as primary hypercoagulable states where you have factor 5 Leiden mutation, where you have prothrombin gene mutation, antithrombin 3 deficiency. So all those are primary hypercoagulable states. So they may be associated with Budd-Chiari. Second, polycythemia. Rubra vera. Patients can have this third PNH. PNH, postpartum. Postpartum. So remember the three P's: polycythemia, PNH, postpartum. Postpartum, that is after delivery. You know, pregnancy is a prothrombotic state. Pregnancy can also lead to thrombi formation. And then, of course, hepatocellular carcinoma. Hepatocellular carcinoma also leads to this. And if you look at liver, if you look at the cut section of the liver, you will see alternating light and dark areas. You know, the areas around the central vein. If you cut the liver and see cut section of the liver, you will see alternating light and dark areas. Dark areas are the areas of congestion, and they will actually be around the central vein. So areas around the central vein will be congested. Areas away from the central vein will be lighter in color. So you have alternating light and dark areas, and you know, the liver, cut section of the liver looks like supari, cut section of supari or nutmeg. So cut section shows nutmeg liver. Nutmeg liver. So congested liver, congestion is around the central vein, so nutmeg liver. So alternating light and dark areas are seen in the liver. So that is about Budd-Chiari syndrome. Okay, now Budd-Chiari syndrome. Okay, now let us come to, this is nutmeg liver. Okay, now let us come to what you call as, let us look at metabolic diseases of liver. Metabolic diseases of liver. Okay, in metabolic diseases, I'll be covering three diseases. Number one, alpha-1 antitrypsin deficiency. 2, Wilson's disease. And 3, hemochromatosis. So here we have alpha-1 antitrypsin deficiency. 2, Wilson's disease. And 3, hemochromatosis. Hemochromatosis. Yes, nutmeg means supari. If you look at supari, cut section of a supari, you will see light and dark areas. So that is nutmeg liver. Okay. So 3. Number 1, first let us look at alpha-1 antitrypsin deficiency. Alpha-1, first metabolic disease of liver is alpha-1 antitrypsin deficiency. Okay, now first, what is this alpha-1 antitrypsin? Okay, now what is alpha-1 antitrypsin? It's an enzyme produced by liver. Okay, what type of enzyme? Alpha-1 antitrypsin is alpha-1 antitrypsin. So it is an antiprotease. So enzyme that breaks other enzymes. Which other enzymes? Proteases. So alpha-1 antitrypsin, it's a protease inhibitor. Protease inhibitor, also referred to as PI. What is alpha-1 antitrypsin? It is a protease inhibitor, or we also call it antiprotease. So what is alpha-1 antitrypsin? It's a protease inhibitor or an antiprotease. That is, alpha-1 antitrypsin is going to break proteases, break enzyme proteases. Okay, so it's a protease inhibitor or an antiprotease. It is produced by liver. You know, hepatocytes in the liver produce it. And it is produced by liver, then from the liver it goes into the blood. From the blood it goes into the lungs. So where does alpha-1 antitrypsin go? It goes into the lungs. And in the lungs, you know, this alpha-1 antitrypsin, it goes into the lungs, this enzyme, and in the lungs it keeps the action of proteases enzymes in check. So it goes to the lungs, and in the lungs, alpha-1 antitrypsin keeps the action of proteases or alpha-1 antitrypsin, it goes into the lungs, and in the lungs it inhibits proteases. So in the lungs now, alpha-1 antitrypsin inhibits proteases in lungs. So in lungs it inhibits proteases. Now, you know, in lungs, who produces proteases? In lungs, you know, enzyme proteases are produced by neutrophils and macrophages. Neutrophils and macrophages, and other cells can also produce this enzyme proteases. Other cells are also there. Okay. Okay, so in lungs, proteases are produced by neutrophils and macrophages. Okay, neutrophils and macrophages in the lungs, they produce these protease enzymes. And people who smoke a lot, in smokers especially, there are a lot of neutrophils and macrophages in the lung in response to the cigarette smoke. So these neutrophils and macrophages, they produce enzyme proteases. And these proteases should be kept in check. Otherwise, in lungs, proteases are produced by neutrophils and macrophages, and these proteases can break, elastic tissue in alveolar septae and cause emphysema in the lung. So, these proteases produced by neutrophils and macrophages in response to cigarette smoke or in response to other environmental pollutants, these proteases can have the capacity to go and break the elastic tissue which is found in the alveolar septae. And if the alveolar septae break, elastic tissue in the alveolar septae break, the emphysema of lung can happen. But normally this does not happen because we all have this alpha-1 antitrypsin which inhibits the proteases produced in the lungs. So alpha-1 antitrypsin is an enzyme. It's a protease inhibitor. It's an antiprotease or a protease inhibitor referred to as PI. It is produced by the liver. Then from the liver it enters the blood. From the blood it reaches the lungs. And in the lungs it inhibits proteases produced by neutrophils and macrophages. These proteases actually have the capacity to break the elastic tissue in the alveolar septae and cause emphysema, but this does not happen because we all have alpha-1 antitrypsin. Okay, now let us come to alpha-1 the gene that produces this alpha-1 antitrypsin is called SIRPINA1 gene. So it's a protease produced by lung and it is produced alpha-1 antitrypsin. This is encoded by SIRPINA gene. So the gene that produces it, SIRPINA1 gene. So which is the gene that produces alpha-1 antitrypsin? That's called SIRPINA1 gene. Okay, now let us come to this. Now, there are at least 75 variants of this enzyme. So 75 variants of enzyme alpha-1 antitrypsin are known. So 75 variants of this enzyme are known, and how do you label them or how do you identify them? By their migration on isoelectric gel. So 75 variants of enzymes are identified, have been identified 75 variants have been identified based on their migration on isoelectric gel. Based on their migration on isoelectric gel. So based on their migration on isoelectric gel, we have identified 75 variants of alpha-1 antitrypsin based on their migration on isoelectric gel. 75 variants have been identified. So in the 75 variants, we have normal variants and we have variants which are called deficiency variants also. Okay. Now let us see alpha-1 antitrypsin deficiency. Let us come to, with this background, let us look at alpha-1 antitrypsin deficiency. Okay, now alpha-1 antitrypsin deficiency is inherited as a codominant trait. So it is inherited as a codominant trait. So it is inherited as a codominant. Inheritance is it is inherited as a codominant trait. Okay, now in alpha-1 antitrypsin deficiency, there is mutation in SIRPINA gene. Okay, so how is alpha-1 antitrypsin deficiency produced? Okay, so normal, we all have something called as PIMM type. PIMM type is the normal variant of alpha-1 antitrypsin. Based on its migration on isoelectric gel, PIMM type is found in most people. This is the normal variant. This PIMM type produces the normal enzyme. This normal alpha-1 antitrypsin keeps the proteases produced in the lungs in check. Then there is a type called PIZZ type. PIZZ type. Now PIZZ type is one of the most common deficiency variant. This is the most common deficiency variant, which is not normal, most common deficiency variant. Now in this PIZZ type, what happens in this PIZZ type, alpha 1, now alpha 1 antitrypsin is a protein, right? And in the hepatocyte, alpha 1 antitrypsin is produced in the endoplasmic reticulum. So normally, the hepatocytes produce, liver produces alpha 1 antitrypsin. In the liver we have hepatocytes. In the hepatocytes, alpha 1 antitrypsin is produced in endoplasmic reticulum. From endoplasmic reticulum, once it is produced, it goes to the Golgi body where it is nicely put in packets. It is packaged, and then from the Golgi body, it comes out of the hepatocytes into the blood and then goes into the lungs. Okay, in PIZZ type, now this is a deficiency, most common deficiency variant. This PIZZ type, this is due to missense mutation. Missense mutation. This PIZZ type is produced due to missense mutation in Serpina 1 gene. There's a missense mutation in Serpina 1 gene. Now, because of this missense mutation, endoplasmic reticulum produces alpha 1 antitrypsin. So, the endoplasmic reticulum of hepatocytes produces alpha 1 antitrypsin. So it does produce alpha 1 antitrypsin, but problem is, this alpha 1 antitrypsin fails to migrate to Golgi body. So it doesn't reach the Golgi body. It fails to migrate to Golgi body because this is produced by there is a missense mutation in the gene. So the alpha 1 antitrypsin is produced in the endoplasmic reticulum, but from the endoplasmic reticulum, it is unable to reach the Golgi body. So it won't come to the Golgi body, it won't go out of the liver, it won't come in the blood, it won't reach the lungs. So as a result, now this abnormal, misfolded protein, misfolded alpha 1 antitrypsin, which is in the endoplasmic reticulum, it accumulates in the endoplasmic reticulum. It accumulates. So misfolded protein accumulates in endoplasmic reticulum of hepatocytes. It accumulates in the hepatocytes, and this now it accumulates in the cytoplasm of the hepatocytes and causes damage to the liver. So this causes damage to liver. Okay, so what do you see? It causes damage to the liver. So patient can have hepatitis. They develop hepatitis, which can progress to cirrhosis. So in damaged patient can have hepatitis. Hepatitis can progress to cirrhosis and increase risk of hepatocellular carcinoma. So hepatitis, which can progress to cirrhosis, and associated with increased risk of hepatocellular carcinoma. So there is damage to the liver. What do you see? Patient develops hepatitis. Hepatitis can progress to cirrhosis and increased risk of hepatocellular carcinoma. And this alpha 1 antitrypsin, which accumulates in the hepatocytes, this is seen as PAS positive globules in the hepatocytes. So alpha 1 antitrypsin accumulates as PAS positive globules in hepatocytes. So it is seen as PAS positive globules in the hepatocytes. Okay. Second, now the endoplasmic reticulum has produced alpha 1 antitrypsin, but this alpha 1 antitrypsin has failed to migrate to Golgi body. So as a result, no alpha 1 antitrypsin in blood. So no alpha 1 antitrypsin in lungs. So no alpha 1 antitrypsin in blood, no alpha 1 antitrypsin in lungs. So now The proteases produced by neutrophils and macrophages, especially if the person is a smoker with alpha-1 antitrypsin deficiency, is a smoker. The lot of proteases are produced by neutrophils and macrophages. They go on breaking the elastic tissue in the alveolar septae and produce pan-acinar emphysema. So there is pan-acinar. This produces pan-acinar emphysema. So there is pan-acinar emphysema. So this produces pan-acinar emphysema. Okay, so the patient ends up with pan-acinar emphysema. So there's early onset emphysema. So alpha-1 antitrypsin deficiency usually presents in young adults. So it presents in young adults. So a young adult with emphysema and cirrhosis of, and can have cirrhosis of, can end up with hepatitis and then cirrhosis of liver. So they can end up with hepatitis and cirrhosis of liver. Treatment is intravenous infusion of alpha-1 antitrypsin, IV infusion of alpha-1 antitrypsin. So alpha-1 antitrypsin IV infusion has to be given. So this is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Okay, I'll be showing you. Okay, let us see the picture. Okay. Okay, we will see this MCQ later. Okay, there is alpha-1 antitrypsin picture. Okay, now look at this picture. So this is a type of history that you get in alpha-1 antitrypsin deficiency. A 23-year-old man with past history of depression presents to primary care physician with increasing shortness of breath. He reports that this occurs especially when he exercises. His family history is pertinent for lung disease in multiple family members. So now see, there is a family history. So it is an autosomal codominant trait. So it is inherited autosomal codominant. So it is an inherited disease, autosomal codominant disease. So there is his family history. So very important is look for family history. So his family history is pertinent for lung disease in multiple family members, but he's not sure which lung disease. He reports that he smokes socially. The shortness of breath, when he smokes socially, the shortness of breath becomes acutely worse. A chest radiograph shows flattened diaphragm and laboratory evaluation reveals increased liver enzymes. He is sent for genetic counselor for genetic testing. So now if you see, this is a lung picture, and now look at liver. This is liver biopsy. Okay, liver biopsy. Okay. Now if you look at this liver biopsy carefully, you can see these pink magenta colored dots inside the hepatocytes. This is pus stain. This is pus stain, and all these round magenta colored dots, these are hyaline globules. So so many hyaline globules inside the hepatocyte. So these are hyaline, these are pus positive globules in the hepatocyte. So they are also called hyaline globules. So these are pus positive globules in hepatocytes. So what you are seeing are pus positive. So I am zooming the picture. You can see these pus positive globules in the hepatocytes. So pus positive globules are seen in the hepatocytes. Okay, so this is alpha-1 antitrypsin deficiency. Okay, next entity in metabolic diseases of the liver that we have to see is Wilson's disease. Wilson's disease. Wilson's disease. It is also called hepatolenticular degeneration. Also called hepatolenticular degeneration. Also called hepatolenticular degeneration. Okay, now Wilson's disease. Okay, before Wilson's disease, little bit about copper. Copper is very important again. So we need copper. Okay, if you look at copper, how copper is absorbed, you know, there is copper comes with the food that we eat, and then copper is absorbed from the duodenum. So copper, if you look at copper is absorbed. Where is it absorbed? It is absorbed from duodenum. It is absorbed from stomach. So what is the site of copper absorption? Stomach and upper small intestine. Upper small intestine. So copper is absorbed from food in the stomach and upper small intestine. Okay, once copper is absorbed, it enters the blood. So copper attaches to albumin in blood. Albumin in blood. So once copper is absorbed, copper comes into the blood. In the blood, copper attaches to albumin. Now this copper bind to albumin goes to the liver. Goes to the liver. And in the liver, this copper in the hepatocytes, this copper combines with apoceruloplasmin to form ceruloplasmin. So in the liver, so in hepatocytes, copper copper combines with apoceruloplasmin. So copper binding protein is ceruloplasmin. So there is something called apoceruloplasmin first. So in hepatocytes, copper combines with apoceruloplasmin. It combines with ceruloplasmin to form ceruloplasmin. So to form ceruloplasmin. So it combines with apoceruloplasmin. So copper combines with apoceruloplasmin to form ceruloplasmin, and now this ceruloplasmin now comes into the blood. Ceruloplasmin. So now there is a protein called ATP7B. So now there is a protein called ATP7B, and this ATP7B now moves ceruloplasmin to blood. So from the liver, from the hepatocytes, it moves ceruloplasmin to blood, and then this ceruloplasmin goes to all the tissues. Goes to all tissues of the body. Tissues of the body. So now very important is a protein called ATP7B. What does ATP7B do? So in the liver, inside the hepatocyte, copper will combine with apoceruloplasmin to form ceruloplasmin, and then this ceruloplasmin will come into the blood via ATP7B. By a protein called ATP7B, it will transport it into the blood, and then ceruloplasmin will go to all the tissues of the body. So it will bind copper and take copper to all the tissues of the body. Thus, copper will reach all the tissues of the body. This copper is important. Tissues need copper because copper acts as a cofactor for many enzymes, for functioning of many enzymes. Enzymes like lysyl oxidase, like tyrosinase, cytochrome C. Many enzymes use copper as a cofactor. So copper is required by all our tissues. So copper binding protein is ceruloplasmin. Ceruloplasmin takes copper to all the tissues of the body. And an important protein that takes this copper bound to ceruloplasmin into the blood is ATP7B. So remember this ATP7B. Okay, ATP7B. So first copper comes in the diet. In the food we eat, in the stomach and upper small intestine, copper is absorbed, copper enters the blood. In the blood, it combines with albumin, and then albumin takes it to the liver. In the liver, inside the hepatocytes, copper combines with apoceruloplasmin to form ceruloplasmin. Then a protein called then a protein called ATP. This is not B. This is not B. This is P. A protein called ATP7B. Takes the ceruloplasmin out of the hepatocyte into the blood, and then ceruloplasmin takes copper to all the tissues of the body, where copper acts as a cofactor for many enzymes. It acts as a cofactor, and it is needed for proper functioning of so many enzymes. Okay, now let us come to, with this background, let us come to Wilson's disease. Wilson's disease. Okay, what happens in Wilson's disease? Number one, it is an autosomal recessive disorder. It's an autosomal recessive disorder where there is mutation in ATP. So there is mutation in ATP7B gene. So there is mutation in this ATP7B gene. So there is mutation in ATP7B. You know what is this ATP7B? As we know, it's a hepatocyte copper transporting ATPase. So ATP7B, this is a hepatocyte. It is a hepatocyte copper transporting ATPase. Copper transporting ATPase. ATPase. So it is a hepatocyte copper transporting ATPase. So there's mutation in this ATP-B7 gene. Now when there is mutation in this ATP-B7 gene, ceruloplasmin cannot come in the blood. Ceruloplasmin cannot come in the blood. So in the hepatocyte, as a negative, so copper will start, or copper levels will increase in the hepatocytes, and copper will spill into the blood. So ceruloplasmin will not be formed. Ceruloplasmin will not be formed. So ceruloplasmin levels will decrease. Tissues will not get copper bound to ceruloplasmin. How do tissues get copper? They get copper bound to ceruloplasmin. So ceruloplasmin will not be formed. And second, now free copper will start spilling into the blood. So there will be excess of free copper into the blood. So excess of free copper in the blood, and this free copper will go and deposit in various organs. Plus this free copper will be excreted in the urine also. So what will you see? So we will see that there will be, copper, so ceruloplasmin, what do we see? So because of this mutation in ATP-B7, now ceruloplasmin not excreted in blood. So no ceruloplasmin, markedly reduced and excreted in blood and bile. So in the blood and bile, ceruloplasmin is not there. And free copper. Now free copper levels increase in blood. Free copper levels increase in blood, that is copper which is not bound to ceruloplasmin. Free copper levels increase in blood, and copper deposits in various tissues. So copper deposits in various tissues. So copper goes and deposits in various tissues. So now if you do lab tests, what will you find? Decreased serum ceruloplasmin levels. So serum ceruloplasmin levels are decreased. Second, what do you see? We see increased serum copper. So increased serum copper levels and increased urine copper levels. So increased serum copper and increased urinary copper excretion. So increased urinary copper excretion is seen. Okay, now copper deposits in various tissues, copper accumulates in various organs. So which are the organs where copper accumulates? Number one, copper accumulates in the liver itself. And in the liver it can lead to liver damage, hepatitis, which can progress to cirrhosis, and increased risk of hepatocellular carcinoma. Second, copper will accumulate in the brain. Okay, in the brain. So copper will accumulate in the brain, producing neurological signs and symptoms. So copper will accumulate in the brain, and patient will have neurological signs and symptoms. So there will be neurologic disease and psychiatric disease also. So copper will accumulate in the brain. So patient has dysarthria. They have dysarthria, dystonia, tremor, and can also develop Parkinsonism. And also develop psychiatric diseases. So they can also develop psychiatric diseases. Okay, third, after brain, copper deposits in the eye. Okay, where in the eye? In the eye, copper deposits in the descent membrane of cornea. Copper deposits in descent membrane of cornea. It deposits in the descending membrane of cornea, and this produces what you call as Kaiser-Fleischer rings. Kayser. Kaiser-Fleischer. So Kaiser, Fleischer, Fleischer rings. So in the cornea we see Kaiser-Fleischer rings. Okay, then copper also causes hemolytic anemia. Hemolytic anemia. So copper also causes hemolytic anemia and kidney damage, renal disease. Renal disease. So it also causes kidney damage or renal disease. And age group patients usually present before the age of 40 with liver disease. So patients present before the age of 40 years with liver disease. So they will come with liver disease before the age of 40 years. So before the age of 40 years, the patient will come with liver disease. So they can have hepatitis, they can have cirrhosis, liver failure. So all those can occur. Increased risk of hepatocellular carcinoma. And treatment is number one, chelation. So you do chelation with penicillamine. So chelation with penicillamine, trientine or trientine. Then second, they are also given oral zinc. So they are also given oral zinc. Oral zinc competes with copper for absorption from the gut. So oral zinc competes with copper for absorption from the gut. So penicillamine and trientine are copper chelating agents. Then you give them oral zinc, which competes with copper for absorption. So this is about Wilson's disease. Okay, coming to the third metabolic disease of liver. Third metabolic disease of liver is hemochromatosis. Hemochromatosis, which is a condition of iron overload. So hemochromatosis, which is iron overload. Okay, now hemochromatosis is primary. So hemochromatosis is basically iron overload. Hemochromatosis is primary and secondary. So we categorize into hemochromatosis into primary and secondary hemochromatosis. Okay, primary hemochromatosis. Secondary hemochromatosis, where do you see? People who iron overload, which is secondary to chronic blood transfusion. So secondary hemochromatosis, this is iron overload secondary to chronic blood transfusions. Blood transfusions. Now, who are the people who need chronic blood transfusions? People who need chronic blood transfusions, example, beta thalassemia major. Thalassemia major. So example, beta thal major. So patients of beta thalassemia major, they require blood transfusions. So they require repeated blood transfusion. So that can cause iron overload and lead to secondary hemochromatosis. Now what I'm going to talk about now is primary hemochromatosis. Primary hemochromatosis is an autosomal recessive disorder. So primary hemochromatosis is an autosomal recessive disorder. So let us come to now primary hemochromatosis. So hemochromatosis can be primary or secondary. Primary is an inherited autosomal recessive disorder. Secondary is seen in conditions where iron overload occurs due to people requiring chronic blood transfusions like patients with beta thalassemia major. Okay, looking at primary hemochromatosis. Okay, now primary hemochromatosis, before we start, let me tell you just few lines. Say if this is a hepatocyte, okay. Now on the hepatocytes, we have receptors for iron. We have receptors for iron. Which are the receptors? Number one, on the hepatocyte, we have something called transferrin receptor 1. Not only hepatocytes, all our cells have these. So we have TFR1 means transferrin receptor 1. Then we also have something called TFR2, transferrin receptor 2, HFE receptor, HFE and HJV. HFE and HJV. Okay, what is the function of these receptors? First, transferrin receptor 1. This is for uptake of iron. Uptake of iron. So you have transferrin receptor 1. What is the function of Transferrin receptor 1. Transferrin receptor 1 is for uptake of iron. Okay, for iron to go inside the cells, we need this. Second, transferrin receptor 2, HFE and HJV. What is the function of these three receptors? They are sensors of iron. Sensors of iron. So these three receptors, they are sensors of iron. Okay, they are not for uptake of iron. They are sensors of iron. So now what do? They are sensors of iron and they induce hepcidin production. Hepcidin production. They induce hepcidin production when iron stores are full. Stores are full. So when iron stores in the body are full, these three people, TF, transferrin receptor 2, HFE and HJV, they will lead to hepcidin production. So they will lead to hepcidin production, and that hepcidin, so they induce hepcidin production, and this now hepcidin will inhibit iron absorption from duodenum. You know, site of iron absorption is duodenum. So if hepcidin is produced, hepcidin will now inhibit iron absorption from duodenum. So what is the function of transferrin receptor 2, HFE and HJV? They are the sensors of iron. How much iron is there in the body? How much iron is there? If there is more iron, they will induce hepcidin production, and that hepcidin, so when iron stores are full, they induce hepcidin production, and this hepcidin will inhibit iron absorption from the duodenum. Okay, now coming to primary hemochromatosis. Primary hemochromatosis is an autosomal recessive disorder which is most commonly due to mutation in HFE gene. So now if any of these three genes, HFE, HJV or transferrin receptors 2, if they are mutated, so if these genes, mutations in the above genes, if gene for transferrin receptor 2, HFE or HJV, if they get mutated, what will happen? If they get mutated, there will be no hepcidin, so no sensing function is lost. So no hepcidin production when iron stores are full. So even when iron stores are full, there will be no hepcidin production. So when there's no hepcidin production, now iron, so there will be no hepcidin production when iron stores are full. So no inhibition of iron absorption. So iron absorption is not inhibited, no inhibition of iron absorption. So iron goes on and on getting absorbed and it deposits in the various tissues of the body. So there is no inhibition of iron absorption, or you can see there iron, no inhibition of iron absorption. So iron accumulates in blood and deposits in various organs. So iron accumulates in the blood and it goes and deposits in the various organs. Okay, now this primary hemochromatosis, what I am talking about, this is an autosomal. So this is the pathogenesis of primary hemochromatosis. So primary hemochromatosis is most commonly due to mutation in HFE gene. So it is an autosomal recessive disorder. Autosomal recessive disorder which is most commonly due to mutation in HFE gene on chromosome 6. So most commonly primary hemochromatosis is due to mutation in this first gene, that is most commonly due to mutation in the second gene, that is HFE gene on chromosome number 6. So most commonly due to mutation in HFE gene on chromosome number 6. So mutation. So as a result, there is abnormal iron sensing and increased iron absorption. So because of this mutation, now there is abnormal, we already know there is abnormal iron sensing. So there is abnormal iron sensing and increased intestinal absorption of iron. of iron and increase intestinal absorption of iron. So if more iron is absorbed, now if you do serum iron studies, if you do serum iron studies, there will be increased serum iron. So increased serum iron. So number one, serum iron level will be increased. Second, TIBC. What is TIBC? Total iron binding capacity. So now there is so much of iron that all that iron will go and bind to transferrin. So the total iron binding capacity of transferrin, that is TIBC, is reduced. So TIBC will be reduced. So the transferrin won't have any more capacity to bind iron because there is so much iron. All the iron will go and saturate the transferrin completely. So TIBC will reduce. Then there will be increased percentage saturation. Increased percentage saturation. I have explained serum iron studies in hematology. So there will be increased percentage saturation of iron and increased serum ferritin levels. All will be increased. So TIBC will be reduced. Serum iron is increased, increased percentage saturation and increased serum ferritin levels. And now all these will be increased. So now iron accumulates in various organs. We saw. So we saw iron accumulates in various organs as we saw. And when iron accumulates in the organ, it damages the organ. How? Iron generates free radicals and it causes damage to the organ. So iron accumulates in various organs and generates free radicals. Free radicals which cause damage. So it generates free radicals which cause damage. So now first organs that are damaged, number one, liver. Liver is damaged. So again in the liver, it causes hepatitis which can progress to cirrhosis with increased risk of hepatocellular carcinoma. Second, iron can deposit in the pancreas also. It can damage the pancreas. Okay. Now, pancreas has two parts, exocrine and endocrine part. Exocrine part produces enzymes that help in digestion of food, and endocrine pancreas, an important function is to produce insulin. So pancreas is damaged, so damage to exocrine pancreas and endocrine pancreas. So now damage to exocrine part of the pancreas which produces enzymes. If that is damaged, exocrine pancreas is damaged, this will produce malabsorption. Patient will have malabsorption. And damage to the endocrine pancreas means no insulin. So this will produce diabetes mellitus. So this will produce diabetes mellitus. Third organ, diabetes mellitus. Third, heart. Iron deposits in the heart, and in the heart it causes dilated cardiomyopathy. So it causes dilated cardiomyopathy. So heart is damaged, causing dilated cardiomyopathy. Then in joints, it deposits in the joints, can cause arthralgias and arthritis. So it can deposit in the synovium also, in the joints. Then testicular atrophy. Deposits in the testis, producing testicular atrophy, and testicular atrophy can lead to infertility. So testicular atrophy can lead to infertility. So it deposits in the testes, can produce infertility. Then skin. Iron deposits in the iron in the form of hemosiderin deposits in the skin. So now skin becomes bronze color. Bronze color of the skin. Bronze color, why? Because of hemosiderin. Hemosiderin deposits in the skin, and also melanocytes produce more and more melanin. So the bronze color of the skin is due to hemosiderin and increased melanin production. So hemosiderin and melanin, these two pigments, they accumulate in the skin and give bronze color to the skin. So they give bronze color to the skin. And in addition, also in pituitary, hemosiderin can deposit in the pituitary. Okay. Now lab, if you do a biopsy of these organs, hemosiderin can be identified. Hemosiderin can be identified. Okay, how can you identify? Hemosiderin can be identified. Number one, when you do a Prussian blue stain on biopsy. Prussian blue is a stain for hemosiderin. So Prussian blue stain on biopsy. So do a biopsy and stain it with Prussian blue stain. And second, hemosiderin can also be identified on liver MRI. So it can be identified on liver MRI. So it can be identified on liver MRI as well as Prussian blue staining. Okay, now we have seen the features. Age at which the patient will present. Age is patients will present after the age of 40, because as the child with this autosomal recessive disorder, that is hemochromatosis, grows, slowly iron will go on and on accumulating in the body, and presentation will occur after 40 years of age, when the total body iron, by that time the total body iron goes more than 20 grams. So age is present after 40 years of age. So patient presents after 40 years of age when total body iron becomes more than 20 grams. So goes more than 20 grams, then they will start presenting. And in females, it can even be later than 40, because in the females they keep losing blood due to menstruation. So the progression is slow of the disease will be slower in women. So they will be slower in women. And then there is this classical triad called bronze diabetes. So classical triad is patient has cirrhosis. So triad of hemochromatosis is cirrhosis with diabetes mellitus and skin pigmentation. So cirrhosis, diabetes and skin pigmentation. It's also called bronze diabetes. Also called bronze diabetes. So it's also called as bronze diabetes. And increased risk of hepatocellular carcinoma. Hepatocellular carcinoma is a common cause of death. So hepatocellular carcinoma is a common cause of death in these patients. Okay, treatment. How do you treat them? Treatment is number one, first line of treatment is repeated phlebotomy. This is the first line of treatment. So first line of treatment is repeated phlebotomy. Second, chelation. So iron chelating agents like deep chelation with drugs like deferoxime. So deferoxime. So one of the chelating agents is deferoxime or deferricirox. Deferricirox can be given. And then when the liver is completely damaged, liver transplant is one of the options that is done for these people. So you do repeated phlebotomy. This is the first line of management. Then chelation, deferoxime and deferricirox, drugs like deferricirox are given. And then of course liver transplant is one of the treatment option. Okay. So this is about the metabolic diseases of liver. Okay, so now let us look at a few questions on these metabolic diseases. Okay. First let us look at this. A 15-year-old Caucasian male is brought to his pediatrician by his parents. So age is 15 years old. So 15 years old male is brought by his pediatrician, brought by his parents to pediatrician, who noticed development of tremor in the child. So the child has tremor. Urine and serum analysis reveals elevated copper. Level. Which of the following clinical manifestation would the physician most expect to see in this patient? Okay, so would most expect to see in this patient. So what is the answer to this? So look at this. So cornea, this is the, so this is cornea. Now this is the story of Wilson's disease. We already know, yes, absolutely correct. Ayush and Adesh, this is, yes, Pooja also correct. So these are Kaiser-Fleischer rings which you see in the cornea. So now remember, so Wilson's disease patients usually they will present before the age of 40, and hemochromatosis they will present after the age of 40. Okay, so now another thing, yes, Rishita, you are also correct. Another thing is, now, when patients, so there is tremor also. So, see, neurological symptoms are also there. So, patients with CNS involvement almost always have KF rings. So, when CNS involvement occurs, they almost always have KF rings, these Kaiser-Fleischer rings also. Okay. Now, look at this next question. 63-year-old woman enrolls in a research, so age is 63 years. Research study evaluating the use of iron studies to screen for disease in population of postmenopausal women. Per study protocol, past medical history and other identifying information is unknown. The patient's iron studies return as follows. Look at serum iron 200 micrograms per deciliter. Normal is 50 to 170. So this is increased. TIBC is 220. Normal is 250 to 370. So serum iron is increased. TIBC is decreased. Then transferrin saturation. Percentage saturation of transferrin is 91%, which is markedly raised. And serum ferritin normal should be up to 150 micrograms per liter. It is now 180 micrograms, which is also increased. Erythrocyte protoporphyrin is within normal limits. Okay, erythrocyte protoporphyrin. Normal is 16 to 65. This is within erythrocyte protoporphyrin. If you remember, it is increased in iron deficiency anemia. When iron is deficient, when there is iron deficiency in the body, erythrocyte protoporphyrin levels will rise. So here they are normal. So here there is no iron deficiency. Rather here there is iron excess in the body. So which of the following is the most likely cause for these findings? So most likely cause. So now this is, you can see this is Prussian blue or Pearl's reaction. Prussian blue stain which is done on liver biopsy, and all this blue colored, I'm zooming the picture. So all these blue colored are hemosiderin deposits in the liver. So all these blue colored what you see are hemosiderin deposits in the liver. Okay. So now which of the following is the most likely cause of these findings? Which of the following is the most likely cause for these findings? So chronic inflammation, excess iron absorption, iron deficiency, lead poisoning, pregnancy. So what is your answer? Okay, yes, absolutely correct. All of you have got it correct. So answer is excess iron absorption. So iron answer here is excess iron absorption. So that is the answer. That is excess iron absorption. Okay, so we'll see this question later. Okay, this is for later. Okay. Okay, now look at this question. Okay, so, okay, now look at this question. A 39-year-old Caucasian male presents for a physical exam. It is noticed that he has slight hepatomegaly. During the history, the patient states that he drinks 7 to 8 beers daily. Biopsy of the liver is shown in figure A. Now first, can you tell me which is the stain used to stain this biopsy? Please write on the chat which is the stain used to stain this biopsy. So what is the primary mechanism for the abnormality seen in figure A? So now tell me I am zooming the picture. First tell me the stain. Second, what all abnormalities do you see in this picture? Two abnormalities. Tell me two abnormalities that you see in this picture. Please write down, then we will see the options. First, which is the stain? I have already shown you this picture. So which is the stain? I wrote there also the name of the stain. Which is the stain here? And what two abnormalities are you seeing in this picture? Please write down on the chat. Yes, very good. So Adesh, good. This is Mason's trichrome. So what is the stain? This is Mason's trichrome, number one. Mason's trichrome is a stain for collagen. So it is a stain for collagen, and collagen appears blue in color. So now the two things that you are seeing in picture is, number one, this is fatty change in the liver, fatty change. So these fat vacuoles are seen in the hepatocyte. So you are seeing, number one, you are seeing fatty change, and second, we are seeing fibrosis. Yes, fibrosis or sclerosis in the liver. So blue colored fibrosis around the central vein and in the perisinusoidal areas. So blue colored fibrosis. So chicken wire fence appearance. Chicken wire fence appearance. Yes, Pooja, absolutely correct. This is Mason's trichrome stain. Okay, now tell me, what is the answer to this question? What is the primary mechanism for abnormality seen in this figure A? So why is fat depositing in the liver? So yes, absolutely, this is chicken wire fence pattern. Okay, so now what is the cause for this abnormality? So what is the answer to this question? So what is the answer to this question? I have already told you this mechanism, the mechanism in detail. So yes, answer is decrease. So absolutely correct, Adesh and Ayush. So it is decreased NAD production. So decreased production of NAD. So NAD is when ethanol is processed in the hepatocytes. First in the cytoplasm. Yes, absolutely correct, Pooja. So ethanol is converted to acetaldehyde by alcohol dehydrogenase. And in that process, NAD gets converted to NADH. So NAD is converted to NADH. Then the acetaldehyde is toxic to hepatocytes. Then that acetaldehyde goes into the mitochondria, and in the mitochondria enzyme aldehyde dehydrogenase converts it into acetic acid. Okay, so NAD is used up. So NAD is converted to NADH. So now since NAD is not there, NAD is required for beta oxidation of fatty acids. So since NAD is not there, beta oxidation of fatty acids cannot happen, and so fats accumulate in the liver producing fatty liver. So producing fatty liver. So that is what we see here. Okay. Next, look at the next question. A 67-year-old male presents to his primary care physician for evaluation of fever and an unintended weight loss of 25 pounds over the last 4 months. He also has decreased appetite and complains of abdominal pain. So decreased appetite, weight loss is there, decreased appetite and abdominal pain located in the right upper quadrant. The patient has not noticed any change in stool or urine. He immigrated from Malaysia to United States 1 year prior. Social history reveals that he smokes half a pack per day and has 5 to 7 drinks of alcohol per day. The patient is up to date on all his vaccinations. Physical examination findings include mild jaundice as well as an enlarged liver edge that is tender to palpation. Based on clinical suspicion, biomarker labs are sent and show polycythemia. So there is polycythemia and elevated alpha fetoprotein levels, but normal CA 19.9 levels. Surface antigen for hepatitis B is negative. Ultrasound reveals a normal sized gallbladder. So there is nothing wrong with gallbladder. Given this presentation, which of the following organism is most likely associated with the development of disease in this patient? So what do you think? Okay, Ayush, you have called. Okay, so what is the answer to this question? Okay, Ayush, you've called it 5. So which trematode from undercooked fish causes? So this is a history of hepatocellular carcinoma. Okay, it is a history of hepatocellular carcinoma. We have ruled out hepatitis B by saying that the surface antigen is negative. So enveloped DNA virus is out, which is hepatitis B. Answer here is A, acute angle branching fungus. This is Aspergillus. Aspergillus which produces aflatoxin. So aspergillus produces aflatoxin. So okay, it is Adesh, answer is not C, because we are writing here surface antigen for hepatitis B is negative. So we have ruled out hepatitis B, which is a DNA virus, as the cause for hepatocellular carcinoma, as the part for hepatocellular carcinoma. Okay, so yes, Yankila, answer is A. So acute angle aspergillus is an acute angle branching fungus. Aspergillus grows in grains which are stored. Okay, and aspergillus produces aflatoxin. Aflatoxin causes hepatocellular carcinoma. So it's aflatoxin that causes hepatocellular carcinoma. Okay. Okay, so aflatoxin causes hepatocellular carcinoma. Okay, I'll give you 15 minutes break now. Okay, and after this I have to cover jaundice. Then I will go to the diseases of biliary bile duct. Then I'll talk about gallbladder and pancreas. Okay, so starting with jaundice. Okay, before jaundice, let us see bilirubin metabolism, which you have already read, in physiology. So which you already know, bilirubin metabolism. Okay, so let us come to bilirubin metabolism. Okay. Okay, so now this picture shows bilirubin metabolism. Okay, you know, now RBCs become old, 120 days lifespan. After that, RBCs die in the RE cells of spleen and liver, etc. So now here, these are senescent RBCs. When RBCs die, hemoglobin comes out. Globin goes to the amino acid pool, and heme now gets converted to biliverdin. These mononuclear phagocytic cells, or the RE cells, they have enzyme heme oxygenase, which converts heme to biliverdin, and then this biliverdin gets converted to bilirubin, and then this bilirubin comes into the blood. Now this bilirubin which comes into the blood is unconjugated bilirubin, and this unconjugated bilirubin now attaches to, forms a complex with albumin. So this unconjugated bilirubin forms a complex with albumin, and now this bilirubin albumin complex enters the liver. It enters the liver for conjugation. So bilirubin gets conjugated inside the hepatocytes in the liver. So now this bilirubin, unconjugated bilirubin, complexes with albumin and it enters the liver. Then in the liver it is taken up by, so bilirubin is drawn here, it's taken up by hepatocytes. Then this unconjugated bilirubin enters the hepatocytes. Then inside the hepatocytes, in the endoplasmic reticulum, it is converted to conjugated bilirubin by enzyme that is called as UDP glucuronyl transferase. So the enzyme that converts unconjugated bilirubin to conjugated is UDP So the name of the enzyme is UDP glucuronyl. So this is called UDP glucuronyl transferase. So the enzyme is UDP glucuronyl transferase. So the bilirubin gets conjugated and bilirubin glucuronides are formed. That is, conjugated bilirubin is formed. Then this conjugated bilirubin comes out of the hepatocytes and it goes into the bile. Then from the bile, it goes into the bile takes it to the intestines. In the intestine, when it reaches the colon, the colonic bacteria deconjugated, or the colonic bacteria convert it into stercobilinogen, or you also call it urobilinogen, and this stercobilinogen is responsible for color of it is passed out in the feces and responsible for color of the feces. Also, some of this bilirubin which has been deconjugated by the intestinal bacteria, some of this bilirubin goes back into the liver for conjugation again. This is called enterohepatic circulation of bilirubin. And also some of this bilirubin which has been deconjugated by the bacteria, it enters the enterohepatic circulation, and it enters the blood, and from the blood it is filtered, it passes in the urine as urobilinogen and is responsible for color of urine. So bilirubin, once bilirubin gets conjugated, it comes out of the liver, it comes into the bile ducts, from the bile duct it comes into the intestine, in the intestine the colonic bacteria deconjugated and they convert it into urobilinogen. Urobilinogen is passed in the stool, responsible for color of stool. You know, this urobilinogen in the stool, we also sometimes call it stercobilinogen. And then this urobilinogen, some of it is absorbed back and goes into the intestine again, goes into the liver again. This is called enterohepatic circulation. And also it is passed in the urine. It is passed by the kidney in the urine. So it is responsible for color of urine. So color of urine. So urobilinogen in the urine, and in the stool it is responsible for color of the stools. So this is the enterohepatic circulation of what we call the this is the what we call as bilirubin metabolism. Bilirubin metabolism. Okay, now let us come to, so after this bilirubin metabolism, let us come to jaundice. So what does the term jaundice mean? So what does the term jaundice mean? Now jaundice is abnormal yellowish discoloration of skin and or sclera. So this is not normal, it is abnormal and it is yellowish discoloration. Yellowish discoloration of skin and sclera. So yellowish discoloration of skin and or sclera, and this is due to increased bilirubin in the blood. Increased bilirubin in blood. So it is due to increased bilirubin in blood. We use the term hyperbilirubinemia. Increased bilirubin in the blood is called hyper. So increased bilirubin in the blood is called hyperbilirubinemia. Okay, now let us look at the causes of hyperbilirubinemia. Causes. Okay, now causes can be divided into two main categories. Conditions where unconjugated bilirubin is increased, conditions where conjugated bilirubin is increased, and conditions where both conjugated and unconjugated bilirubin is increased. So causes are divided into the first category, unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. This is a condition where unconjugated hyperbilirubinemia. Now you know there's a test that is done for which used to be done for detection of bilirubin in the blood, which used to detect both conjugated and unconjugated. So that was Vandenberg test. So there was something called direct Vandenberg's test and indirect Vandenberg's test. So indirect Vandenberg's test is for unconjugated bilirubin and direct Vandenberg's test is for conjugated bilirubin. So unconjugated bilirubin is also called indirect bilirubin. So unconjugated bilirubin is also called indirect acting or indirect bilirubin. So it's also called indirect bilirubin because of the test that we do to detect unconjugated bilirubin, that is, it is called indirect bilirubin. Okay, now causes of unconjugated. So which are the conditions where unconjugated bilirubin increases in the blood? So this happens in hemolytic anemias. So in hemolytic anemias, a lot of RBCs are dying. So when a lot of RBCs are dying, a lot of bilirubin is being generated. Unconjugated bilirubin is produced and liver is unable to conjugate all of it because lots and lots of it is produced. So unconjugated bilirubin rises in the blood. So here now we have hemolytic anemias. Hemolytic anemias. Second is physiological jaundice of newborn. Physiological jaundice of newborn. Okay. In physiological jaundice of newborn also unconjugated bilirubin is increased because in the newborn liver, the enzyme that is needed for conjugation, the name of the enzyme is UDP glucuronidase transferase. That enzyme is very immature, or it is less in amount, or it is very immature. So bilirubin cannot be conjugated. So unconjugated bilirubin rises. Third is there are two hereditary hyperbilirubinemias which we will see later. They are Crigler-Najjar syndrome and Gilbert syndrome. and Gilbert syndrome. Gilbert syndrome. Both these are inherited syndromes which are associated with increased unconjugated bilirubin. So unconjugated or indirect acting bilirubin, unconjugated bilirubin is also called indirect acting bilirubin. Causes of conditions where unconjugated bilirubin is increased are hemolytic anemia, physiological jaundice of newborn, Crigler-Najjar syndrome and Gilbert syndrome. So second category is condition where conjugated bilirubin is increased. So that is called conjugated bilirubin is called direct acting bilirubin. So conjugated hyperbilirubinemia. Hyperbilirubinemia. So conjugated hyperbilirubinemia. What are the causes? So causes are, now everything is all right. In the liver, in the hepatocytes, bilirubin is getting conjugated. But conjugated bilirubin cannot come out. Either cannot come out, conjugated bilirubin does not reach the intestines because there is bile duct obstruction or biliary tract disease or other defects, inherited hereditary hyperbilirubinemias like Dubin-Johnson and Rotor. So conjugated bilirubin is getting conjugated, but this conjugated bilirubin cannot come out of the liver. So this is seen in number 1, biliary tract obstruction. So if there is obstruction to the flow of bile, so this is seen number 1 in biliary tract obstruction. Biliary tract obstruction can be due to gallstones. So biliary tract obstruction can be due to gallstones. Then liver fluke infestation. Then also due to obstruction can be produced by malignancies, like malignancies of bile duct. Malignancy of bile duct is cholangiocarcinoma. Then liver, hepatocellular carcinoma, liver or pancreatic cancer can also cause obstruction of the bile ducts. So liver cancer or pancreatic ceiling. All can cause obstruction of the bile ducts and prevent the flow of bile. So this is biliary tract obstruction. Second is biliary tract disease. So if there is a disease of the biliary tract, so biliary tract disease, again conjugated bilirubin will not be able to go out in the stool. So here the two important diseases are primary sclerosing cholangitis and primary biliary cirrhosis. Primary sclerosing cholangitis and primary biliary cirrhosis. So primary sclerosing cholangitis and primary biliary cirrhosis. And third cause is hereditary excretion defects, what is called as excretion defects. So the first two causes are biliary tract obstruction or biliary tract disease where bile ducts are defective. Third cause is excretion defect. Now what is excretion defect? Inside the hepatocyte, the bilirubin is getting conjugated, but it is unable to come out of the hepatocyte. So it doesn't come out of the hepatocyte. So that is excretion defect, which is seen in Dubin-Johnson syndrome and Rotor syndrome. So this is seen in Dubin-Johnson and Rotor syndrome where there is excretion defect. So these are the causes for conjugated hyperbilirubinemia. And third category is mixed, where both conjugated and unconjugated bilirubin are increased. So third category is mixed, where both direct and indirect bilirubin is detected. So there is mixed hyperbilirubinemia. So mixed hyperbilirubinemia. This is seen in hepatitis and cirrhosis. So mixed hyperbilirubinemia, which is seen in hepatitis and cirrhosis of liver. Okay, hepatitis and cirrhosis of liver. Okay, now we look at the findings also. So very common, if you see, first, unconjugated hyperbilirubinemia, very common cause is hemolytic anemia. So when hemolytic anemia patients have jaundice, we call it hemolytic jaundice. Second is very common cause of conjugated hyperbilirubinemia is obstruction to the biliary tract by gallstones being very, very common. So the jaundice here is also called obstructive jaundice. And third is in mixed category, very important causes are hepatitis and cirrhosis both. And thus this is also called hepatocellular jaundice. So we should be able to differentiate between these three. So let us see findings in obstructive jaundice. Obstructive jaundice. What are the findings in obstructive jaundice? So obstructive jaundice, which bilirubin will increase? In obstructive jaundice, it is conjugated bilirubin which is increased. So increased conjugated bil. So which is hyperbilirubinemia that you see is conjugated bil. Second, urine. In the urine, where will you find urine bilirubin? Okay, now in conjugated hyperbilirubinemia, as in obstructive jaundice, bilirubin is getting conjugated, but because of obstruction, conjugated bilirubin cannot pass out into the bile, go into the intestines, cannot pass out in the urine and stools. So since there is no bilirubin in the stools become clay colored. Okay, now conjugated bilirubin levels rise in the blood, and you know conjugated bilirubin is water soluble. Unconjugated bilirubin is not water soluble, conjugated bilirubin is water soluble. So when unconjugated bilirubin, because of obstruction, it cannot pass out through the stool or cannot pass in the urine, then stools become clay colored, one, and two, the conjugated bilirubin spills into the blood because it is water soluble and it is excreted by the kidneys. So there is bilirubin is excreted in the kidney. So urine bilirubin is present in obstructive jaundice. And urine urobilinogen. So now since conjugated bilirubin because of obstruction cannot reach the intestine, urobilinogen cannot form. So since urobilinogen cannot form, there is no urobilinogen in the urine. So this is what we see in obstructive jaundice where you have conjugated hyperbilirubinemia. So conjugated bil is increased, there is bilirubin present in the urine and there is no urobilinogen in the urine. Second is hemolytic jaundice, which you see in hemolytic anemia. Now here there is increased unconjugated bil. So unconjugated bilirubin is increased. Now we know unconjugated bilirubin is not water soluble. So intact bilirubin will not pass out in the urine. So urine bilirubin is negative. So bilirubin in the urine is negative. But urobilinogen, whatever bilirubin is getting conjugated, unconjugated bilirubin is going to the liver. Not all is getting conjugated. Whatever is getting conjugated, urobilinogen is being formed and urobilinogen is excreted in the urine. So urobilinogen is present in the urine. And last is hepatocellular jaundice, where you have mixed hepatocellular jaundice. Here you have increased conjugated plus increased unconjugated bill. Both are there. Conjugated bill, both are increased. So increase conjugated and unconjugated bill. So conjugated bill, when it increases, it will pass in the urine. So urine bilirubin will be present. And unconjugated bilirubin will be conjugated by the liver. So urobilinogen will be normal in the. So it will be unconjugated bilirubin will be conjugated in the liver, then it will go into the intestine, urobilinogen will form and urobilinogen will be normal in the urine. Urobilinogen will form in the urine. So I hope all of you have understood this part. Anyone has any doubts? So you should know this because there are questions based on this. All of you, Ayush, Pooja, Adesh, Yankila and who are the others? All of you, I hope you have understood this part. Okay. Now few lines on physiological jaundice of newborn. Physiological jaundice of newborn. So physiological jaundice on. Okay, Adesh, obstructive part. Okay, now you see, okay, Adesh, what is obstructive jaundice? So now say this is liver. We have already seen what are the causes for obstructive jaundice. What is obstructive jaundice? Biliary tract obstruction. Most common cause for obstructive jaundice is gallstones. Second, liver flow, cholangiocarcinoma. Whenever there is obstruction to the flow of bile, that causes obstructive jaundice. Okay, then biliary tract diseases can also cause obstruction. Okay, now in obstructive jaundice, what happens? So now this is the liver and bile comes out of the conjugated bilirubin. So conjugated bile now comes out into the bile duct. So conjugated bilirubin, for example, there is a stone here. So conjugated bile has come out. It comes out, but there is a stone here in the bile duct. For example, there is a stone here in the bile duct. So conjugated bilirubin cannot reach the intestine. Can the bile flow into the intestine? So bile cannot flow into the intestine. So conjugated bilirubin cannot go into the intestine. You know, in the intestine, conjugated bacteria act on the conjugated bilirubin and convert it into urobilinogen. So urobilinogen, and that urobilinogen is absorbed in the blood and is passed out by the kidney in the urine. So since there is obstruction to the flow of conjugated bilirubin to the intestine, urobilinogen is not there. No urobilinogen. So because urobilinogen will not form. Second, there is no urobilinogen in the stool also. So stool will become, they will become pale stools. Pale or clay colored, what you call clay colored stools. Clay colored stools, because you know urobilinogen is responsible for color of stools and also for color of urine. So since no urobilinogen is forming, so urine will have no urobilinogen in urine and stools will also have no urobilinogen, thus making the stools clay colored. So clay colored stool, no urobilinogen in the urine also. Okay, now the conjugated bilirubin is going on accumulating in the liver. This conjugated bilirubin goes in the blood. So now there is increased conjugated bil in blood. So it will be absorbed it will go into the blood. So increased conjugated bilirubin in the blood, and since conjugated bilirubin is water soluble, this conjugated bilirubin will be excreted by kidney. So since it is excreted by the kidney, so you will find bilirubin in urine. So bilirubin will come in the urine, but no urobilinogen in the urine, no urobilinogen in the stools. So because of bilirubin in the urine will become dark colored. Okay, so this is what we see. Okay, now few lines on physiological jaundice. Physiological jaundice of newborn. Okay, physiological jaundice of newborn. Okay, so physiological jaundice of newborn, it produces increased unconjugated bile. So it's a cause for unconjugated hyperbilirubinemia. Okay, now why is bilirubin not getting, it is coming into the liver but it is not getting conjugated? Cause is number one, in a newborn liver, the enzyme UDP gluconyl transferase is immature. So number one, immature UDP gluconyl transferase. So the enzyme UDP gluconyl transferase number one is immature. So this is immature, and so at birth this enzyme UDP gluconyl transferase is immature at birth. And also another cause is decreased hepatic uptake of conjugated bilirubin. So conjugated bilirubin cannot enter inside the hepatocyte because there are proteins called ligands which are needed. So if this is a hepatocyte and this is unconjugated bilirubin. Unconjugated bilirubin enters inside the hepatocyte and then it gets conjugated there. So there are proteins called as ligands. So ligands are responsible for taking it inside, unconjugated bilirubin inside the hepatocyte. So decreased hepatic uptake as in a newborn liver, ligands are also decreased. So due to decreased ligands. So decreased hepatic uptake. So main is immature UDP glucuronate transferase. You can remember this one also. And second is decreased hepatic uptake because the ligands in newborn liver, ligands are also less. So now as a result of this, there is increased unconjugated bill. Increased unconjugated bill. The child will have jaundice. The child will have jaundice. So the newborn will have jaundice in newborn. So the newborn will have jaundice 1. 2. Sometimes if the bilirubin level is high, bilirubin can also cross the blood-brain barrier and reach the brain. When it reaches the brain, this is called as kernicterus. So there can be kernicterus. So what is kernicterus? Now bilirubin deposits in the brain. Bilirubin deposits. So what is kernicterus? Bilirubin deposits in brain, especially in the basal ganglia. Especially in basal ganglia. So bilirubin deposits in the brain, especially in the basal ganglia of the brain, producing kernicterus. And you know, this physiological jaundice of newborn, it occurs after first 24 hours of life. So child is born, after 24 hours this jaundice will occur. So occurs after 24 hours of birth. So jaundice occurs after 24 hours of birth and it usually resolves on its own. Usually resolves without any treatment. Without treatment in 1 to 2 weeks. So it usually resolves without any treatment in 1 to 2 weeks. If treatment is required, so usually it will become alright without any treatment, time is 1 to 2 weeks. If treatment is required, then phototherapy is given. So phototherapy, this is non-UV rays. Non-UV, so phototherapy is given. What does this phototherapy do? You know, this phototherapy, it isomerizes unconjugated bilirubin and converts it into a water-soluble form. So it isomerizes unconjugated bill and it is converts it into water-soluble form. Converts it into water-soluble form. So it isomerizes, so this phototherapy isomerizes this unconjugated bilirubin and converts it into water-soluble form. So that is about physiological jaundice of newborn. Now coming to hereditary hyperbilirubinemias. Hereditary hyperbilirubinemias. So now coming to hereditary hyperbilirubinemias. Okay, in hereditary hyperbilirubinemias, I will talk about 4 entities. Number 1, I will talk about Gilbert syndrome. Gilbert syndrome. I'll talk about Gilbert syndrome and Crigler-Najjar. Crigler-Najjar syndrome. Both Gilbert and Crigler-Najjar, they cause unconjugated hyperbilirubinemia. So they cause unconjugated hyperbilirubinemia. So they increase unconjugated bilirubin. And second, I will talk about Dubin-Johnson and Rotar syndrome. Dubin-Johnson and Rotar. Dubin-Johnson and Rotar both cause conjugated hyperbilirubinemia. So they increase conjugated bilirubin levels. All hereditary hyperbilirubinemias are autosomal recessive. So all are autosomal recessive. So all, whether conjugated or unconjugated hyperbilirubinemias, all are autosomal recessive. Okay, so first let us see unconjugated hyperbil, the ones causing unconjugated hyperbil. So here number 1, Gilbert syndrome. Gilbert syndrome. So number 1 is Gilbert syndrome. Okay, now in Gilbert syndrome, you know, Gilbert syndrome is very common. It's very common. It is very common and usually it doesn't cause any problem. So very common, no clinical consequence. Okay, what is the problem in Gilbert syndrome? In Gilbert syndrome, it's an autosomal recessive disorder, and in this disorder, there is mild deficiency of UGT glucuronidase transferase. So there is mild deficiency of UDP glucuronidase transferase. So the conjugating enzyme UDP glucuronidase transferase is mildly deficient. So there is mild deficiency of the enzyme, plus also there is impaired bilirubin uptake. Also there is impaired bilirubin uptake by the hepatocytes. Uptake by hepatocytes. So unconjugated bilirubin also is unable to enter inside the hepatocyte. And second, so there is impaired hepatic uptake, and very important, there is mild deficiency of enzyme as well. So now clinical features, usually patient is asymptomatic. They are asymptomatic or they have mild jaundice. Mild jaundice. And you know this, they develop this jaundice, they have mild jaundice, usually which increases with fasting and stress. So if they have a lot of tension, so mild jaundice which is increases with fasting and stress. So they have mild jaundice with which increases with fasting and stress. And serum bill is usually less than 3 milligrams per deciliter. So how much is the serum bilirubin level? It is usually less than 3 milligrams per deciliter. So serum bilirubin. So you know, in patients with Gilbert syndrome, we have to rule out hemolytic anemia also. So there is no hemolysis. So there is increased serum unconjugated bill without hemolysis. So serum bill is usually less than 3. So there is increased serum unconjugated bill without hemolysis. Okay. So this is first, that is Gilbert syndrome. Second syndrome is Crigler-Najjar. Crigler-Najjar syndrome. Crigler-Najjar syndrome. Now Crigler-Najjar syndrome is of two types, type 1 and type 2. Type 2. Okay. Type 1 now is in type 1. Type 1 Crigler-Najjar. In type 1 there is complete absence of UDP glucuronidase transferase. So there is absent UDP glucuronidase transferase. So this enzyme UDP glucuronidase transferase is completely absent, and the child presents early in life. So they present early in life. So complete absence of the enzyme, present early in life, and you know, present early in life and die within few years. So it is usually fatal, die within a few years. So they die within a few years. Okay. So now what are the clinical features? What are the findings that these children have? What are the findings? So in the findings they have number 1 jaundice. They have jaundice 1. 2 kernicterus. So kernicterus. So second they have kernicterus. And you know, kernicterus leads to, what will kernicterus lead to? Kernicterus will lead to lethargy and decreased muscle tone. Kernicterus results in lethargy and decreased muscle tone. So kernicterus results in lethargy and decreased muscle tone. And of course, their jaundice, they have kernicterus, which leads to lethargy and increased muscle tone. Kernicterus is the unconjugated bilirubin is crossing the blood-brain barrier, and it is depositing in the brain, especially the basal ganglion, and increased unconjugated bill in the blood. So you see increased unconjugated bilirubin in the blood. Treatment for this severe variety, that is type 1, treatment is plasma pheresis and phototherapy. Okay, now what will plasma pheresis do? Plasma pheresis, you know, this unconjugated bilirubin, it complexes with albumin. It binds to albumin, is bound to albumin. So now this plasma pheresis rapidly removes albumin that is tightly bound to unconjugated bilirubin. So plasma pheresis, it removes albumin that is tightly bound to unconjugated bill. So unconjugated bill, we know it bonds to albumin. So plasmapheresis is going to remove this albumin. So unconjugated bilirubin will also get removed. Okay, type 2 is less severe. Type 2 is less severe, and in type 2 the treatment is phenobarbital. Phenobarbital is given. You know this phenobarbital, how does it act? So type 2 is less severe. So phenobarbital, it increases the liver, it stimulates the liver to produce more UDP glucuronidase transferase. So this increases liver synthesis, increases liver enzyme synthesis. So it increases the synthesis of UDP glucuronidase transferase by the liver. Okay, now coming to conjugated hyperbilirubinemia. Two diseases that cause conjugated hyperbilirubinemia, they are Dubin-Johnson and Rotar syndrome. So first is Dubin-Johnson syndrome. So here we have two diseases, Dubin-Johnson syndrome and Rotar syndrome. So first is Dubin-Johnson. Okay, now in Dubin-Johnson, bilirubin is getting conjugated in the hepatocytes. For example, this is a hepatocyte. This is a hepatocyte here. These are two hepatocytes. Between the hepatocytes, we know there are bile canaliculi. Okay. Now, so they are shaped something like this. So these are the bile canaliculi here. Okay, so now you know the problem in Dubin-Johnson is defective liver excretion. So these are bile canaliculi. So now conjugated, once bilirubin gets conjugated, so conjugated bilirubin will cross these bile canaliculi and they will come here. So they will cross this hepatocyte membrane and they will enter the bile canaliculi. So this is the membrane of the bile canaliculi. So now in Dubin-Johnson syndrome, there is increased conjugated bill. Conjugated bill is increased due to defect in liver excretion. So there is defect in liver excretion. Liver is unable to excrete this conjugated bilirubin into the bile canaliculi. Now cause, what is the cause here? Cause is mutation in canalicular. There is mutation in a protein which is found on the bile. There is a protein found on bile canalicular membrane which helps in excretion of this conjugated bilirubin. So there is mutation in canalicular multi-drug resistant protein. So there is mutation in canalicular multi-drug resistant protein. So there is mutation in canalicular multi-drug resistant protein 2, that is multi-drug resistant protein MDR2. So because of mutation in this canalicular multi-drug resistant protein 2, there is impaired biliary excretion of conjugated bilirubin into the canaliculi. So there is impaired biliary excretion of conjugated bil into bile canaliculi. So conjugated bil cannot come out into the bile canaliculi. So normally, so this does not happen. Conjugated bil cannot come out into the bile canaliculi. So it cannot happen because there is mutation in canalicular multi-drug resistant protein. So on the hepatocyte membrane, on the canalicular membrane, we have this multi-drug resistant protein 2, which takes the conjugated bilirubin out into the bile canaliculi. But here the protein is mutated, the protein is not there. So there is impaired biliary excretion of conjugated bilirubin into the bile canaliculi. And you know, here it is a benign condition. Dubin-Johnson is a benign condition, and very characteristic is it's a benign condition. Second, if you look at the liver, grossly liver is black in color. liver is black in color. Black in color. So in Dibben-Johnson syndrome, you have black colored liver. Now, why is the liver black in color? Because of accumulation of polymers of noradrenaline in the liver. So polymers of noradrenaline accumulate in the liver and make the liver black in color. Okay, second syndrome in this category is Rotor syndrome. Rotor syndrome. Okay, Rotor syndrome is similar to Dubin-Johnson. Okay, in Rotor syndrome now, milder presentation compared to Dubin-Johnson, milder presentation 1 and 2, no, liver is not black in color. Liver is not black in color. Black in color. So in Rotor syndrome also there is increased conjugated bill. We already know increased conjugated bill. It is conjugated hyperbilirubinemia. It is the milder presentation as compared to Dubin-Johnson, and liver is not black in color. And this is due to, again, due to impaired hepatic excretion. This is also due to impaired hepatic excretion of conjugated bill. This is also due to impaired hepatic excretion of conjugated bill. Now this is associated with mutation in SLCO1B1 and SLCO1B3 genes. So this is due to mutation in SLCO1B1 and SLCO1B3 genes, and this mutation in these associated with mutation in SLCO1B1 and SLCO1B3 genes, and this leads to defect in hepatic storage of conjugated bilirubin. So this results in defect in hepatic storage of conjugated bill, which results in defect in hepatic storage of conjugated bill. So there is defect in hepatic storage of conjugated bilirubin. So this is what we see in Rotor syndrome. So these are 4 hereditary hyperbilirubinemias. Okay, now let us come to biliary tract disease. Biliary tract disease. So biliary tract diseases. Okay, in biliary tract diseases, I'll be talking about 3 diseases. Number 1, primary sclerosing cholangitis. Number 2, primary biliary cirrhosis. And number 3, secondary biliary cirrhosis. Okay, now first, patients with these 3 biliary tract diseases, or patients with, whenever there's a disease in the biliary tract, how will the patient present? Patient will present with obstructive jaundice. So biliary tract disease will cause obstruction of the bile ducts leading to obstructive jaundice. So clinical features, patients will present number 1 with pruritus. Okay, why pruritus? Now there is obstruction to flow of bile. Biliary tract disease will produce an obstruction to the flow of bile. Since there is obstruction to the flow of bile, bile salts, bile pigments, and this conjugated bilirubin cannot pass out in the stools, cannot go out, cannot reach the intestine and cannot pass out. So now levels of bile salts in the blood will rise, and these bile salts will deposit in the skin, causing pruritus. So pruritus is due to deposition of bile salts in skin. So bile salts deposit in the skin, causing pruritus. Second, there is jaundice. So patient will present with jaundice. 3, dark urine. Why? Due to passage of conjugated bill in the urine. So conjugated bill is water soluble. In biliary tract disease, conjugated bilirubin is unable to come out because of obstruction, come out of the liver because of obstruction in the bile ducts. So conjugated bilirubin is unable to come out because of obstruction in the bile ducts. So conjugated bilirubin level in the blood rises. Conjugated bilirubin, being water soluble, is passed out in the urine, and urine becomes dark in color. Second, light colored stools. Light colored stools. So stools are pale or light in color because there is no urobilinogen, in stool. So because there is no urobilinogen in stool, urobilinogen is responsible for color of stool. So color of stools. In addition, patient can also have hepatosplenomegaly. If you look at liver function tests in patients with biliary tract disease, liver function tests, what will we see? We will see increased conjugated bil, number one. So conjugated bilirubin is increased. Second, in biliary tract diseases, enzyme alkaline phosphatase, if you remember, we had written alkaline phosphatase rises. So increased alkaline phosphatase. Okay, and three, now since there is obstruction to the flow of bile, you know, cholesterol is also excreted via bile. So cholesterol is also excreted via bile and passes through the intestines and into the stool. So cholesterol is also excreted via bile. So now since there is obstruction to flow of bile, now there is increased serum cholesterol levels also. So in obstructive jaundice, which is produced by biliary tract disease, conjugated bilirubin levels will rise. Alkaline phosphatase, which is an enzyme that comes out of the bile ducts, that also rises, and serum cholesterol also rises. So we see these features. Now let us come to these diseases. First disease in this category is primary sclerosing cholangitis. So first disease is primary sclerosing cholangitis. Now primary sclerosing cholangitis, etiology of the disease is not known. So now, okay, now it is a disease of which can involve both intra and extrahepatic bile ducts. And it usually involves large intra and extrahepatic bile ducts. So what do you see in primary? Primary means cause not known. Sclerosing means fibrosis. Cholangitis means inflammation. So large intra and extrahepatic bile ducts get inflamed. After getting inflamed, they are surrounded by fibrous tissue. And fibrosis obliterates the ducts. Okay, once again let us see. Say if this is a large bile duct. First, primary sclerosing cholangitis is a segmental disease. Segmental means it doesn't involve the whole duct in a continuous fashion. There are skip lesions. There are sort of skip lesions. So say this portion of the duct is involved, and then part of the duct is spared, and then next again this portion of the duct is involved. So now this portion of the duct, it will be inflamed. In the wall of the duct. There will be inflammatory cells. Then after inflammation, so there will be inflamed duct. After inflammation, there will be fibrosis around the duct. And you know, this fibrosis is laid in a concentric fashion around the duct. So it's called onion skin fibrosis. Cut section of onion. You have so many layers inside. Similarly, the duct will be surrounded by so many layers of fibrous tissue. So fibrosis around the duct. This is onion skin fibrosis. And this onion skin fibrosis, now what will happen to this portion of the duct? This portion of the duct will get obliterated like this. So this will be obliterated. Then the remaining normal segment will dilate. Then again the duct will get obliterated. So now this is what you see, the disease portion, the inflamed portion, which is followed by fibrosis. This will get obliterated. So this is obliterative fibrosis of duct. This is normal segment of the duct dilates. So normal segment will dilate. So this is what we see is in primary sclerosing cholangitis. So now let us lie down with this understanding. Number one, unknown etiology. So primary sclerosing cholangitis, it's an unknown etiology. It is a disease of large intra and extrahepatic bile ducts. Bile ducts. So which are the ducts involved? Large, intra and extrahepatic bile ducts. Third, it is a segmental disease. segmental disease. So segmental disease means there are skip lesions. It doesn't involve the entire duct in a continuous fashion. And now what do you see? There is inflammation and concentric onion skin fibrosis of duct. So there is inflammation and concentric onion skin fibrosis of ducts. And this concentric onion skin fibrosis, this produces obliteration of parts of ducts. So parts of the ducts get obliterated. So parts of the duct get obliterated and the uninvolved parts dilate. Uninvolved segment of duct dilates. So uninvolved segment of the duct dilates. So this now produces a beaded appearance on ERCP. So this produces, so on radiology you see a beaded appearance of ducts. So what do you see on radiology? You see beaded appearance on duct. So beaded appearance is seen on radiology. What do? You do an ERCP or you do an MRI, magnetic resonance MRCP. If you do an ERCP or MRCP is magnetic resonance cholangiopancreatography. So on MRCP or ERCP, you see beaded appearance of the drugs. So we see beaded appearance of the duct. Okay, now this is clinical features. We already have discussed the clinical features. It is seen in middle-aged men. So seen in middle-aged men. So middle-aged men, and very important, association with ulcerative colitis. So primary sclerosing cholangitis is associated with ulcerative colitis. And if you do a serology, these people, they are positive for P-ANCA. So ulcerative colitis can also be associated with P-ANCA. So primary sclerosing cholangitis have P-ANCA plus increased IgM levels in blood. So IgM antibody levels in blood are associated. Okay, now these people, they are at increased risk of developing. So they are at increased risk of developing bile duct cancer, that is cholangiocarcinoma, and even gallbladder cancer. So increased risk of developing cholangiocarcinoma and also gallbladder carcinoma. So increased risk of developing cholangiocarcinoma and gallbladder cancer. So this is primary sclerosing cholangitis. Okay, second entity is primary biliary cirrhosis. Primary biliary cirrhosis. Now the new name for primary biliary cirrhosis is primary biliary cholangitis. It's also called primary biliary. New name is primary biliary cholangitis. Okay, now what is this primary biliary cirrhosis? Number one, it's an autoimmune disease, more common in females. Okay, autoimmune disease, more common in females. Second, now which bile ducts does it involve? It involves only the intrahepatic bile duct. Okay, in intrahepatic also it is a disease wherein small and medium-sized intrahepatic bile ducts are destroyed by formation of granulomas in the liver. So lymphocytes and granulomas, they come and they destroy the intrahepatic bile ducts. So primary biliary cirrhosis is an autoimmune disease. Now it is an autoimmune disease. In this autoimmune disease, there is destruction of small and medium-sized intrahepatic bile ducts. So there is destruction of small and medium-sized intrahepatic bile ducts like the intralobular bile ducts. So which are inside the lobule of the liver. Intralobular bile ducts by lymphocytes and granulomas. So granulomas are formed in the liver. So lymphocytes and granulomas come and they destroy the small and medium sized intrahepatic bile ducts like the intralobular bile ducts. And this is classically seen in middle-aged females. Middle-aged females. So it is seen in middle-aged females. And if you see their serology, these females are positive for anti-mitochondrial antibodies. So they have anti-mitochondrial antibodies. Most of these women have anti-mitochondrial, 95% patients have anti-mitochondrial antibodies. So this is seen in 95% patients. Other than this, they may also have anti-nuclear antibodies, ANAs, anti-nuclear antibodies, and anti-smooth muscle, SMA antibodies. SMA stands for anti-smooth muscle antibodies. Then these females may have other autoimmune diseases also. They may have other, AID stands for autoimmune disease. So these females may have other autoimmune diseases also like Sjogren's syndrome. So they may have other autoimmune diseases like Sjogren's, Hashimoto's thyroiditis. So they may have other autoimmune diseases like Sjogren's, Hashimoto's thyroiditis, rheumatoid arthritis, or celiac disease. So they may have other autoimmune diseases like Sjogren's, Hashimoto's thyroiditis, rheumatoid arthritis, or celiac disease. So this is about primary biliary cirrhosis. Last is secondary biliary cirrhosis. Next bile duct disease is secondary biliary cirrhosis. So now we already know secondary biliary cirrhosis is extrahepatic bile ducts are obstructed due to various reasons. So in secondary biliary cirrhosis, this is due to obstruction of extrahepatic bile ducts. So this is due to obstruction of extrahepatic bile ducts, and most commonly these extrahepatic bile ducts are obstructed by gallstones. So most common obstructed by gallstones. Second, biliary strictures. Biliary strictures can also obstruct these stones. And carcinoma pancreas can also obstruct the if it's a big mass, it can obstruct the extrahepatic bile ducts. So now when there is obstruction to the bile ducts, extrahepatic bile ducts, because of the obstruction, there is increased pressure in the intrahepatic bile ducts also. And now that causes injury to the liver. There is fibrosis resulting in cirrhosis. So this causes increased intrahepatic. So this causes so this leads to increased pressure in the intrahepatic ducts as well. Increased pressure in intrahepatic ducts. So if there is an extrahepatic obstruction, the pressure in the intrahepatic ducts increases. So increased pressure in intrahepatic ducts. So now this will cause number one, stasis. So this is going to cause bile stasis. So this leads to bile stasis, 1, and 2, increased pressure in the intrahepatic duct also causes bile duct injury and fibrosis in the liver. So fibrosis will progress to cirrhosis. They may progress to cirrhosis. Okay. So these are the 3 biliary tract diseases which we have to know. Okay, now let us look at the questions first. Few questions. Okay, now look at this. This is a type of history. 24-year-old medical student is 2 weeks into her first surgery rotation when her senior resident tells her that her eyes look a little yellow. She experienced her first needle stick injury in the operating room just 1 week earlier and began to worry about hepatitis. Other than rarely having time to eat at work, she has no other complaints or symptoms. So what do you think? This is the history of 24-year-old medical student who has just come into surgery, and her eyes look yellow, needle stick injury was also there, and she doesn't get time to eat at all. So what do you think this is the history of? Okay, this is the characteristic history of, she had first needle stick injury in the operating room and she worried about hepatitis, but this actually is the history of Gilbert syndrome. Gilbert syndrome, where her eyes look yellow and she has a lot of stress, and the stress, in the stressful period she has developed jaundice. So this is the history of jaundice, history of Gilbert syndrome, where needle stick injury has also been given to you to confuse, to create confusion. So she just has mild jaundice and her eyes look yellow, and she has no other complaints or symptoms. So if it is hepatitis, there may be other complaints and symptoms also. Okay, look at this question. A 1-week-old boy presents with yellow sclera, severe lethargy and decreased muscle tone. So if you see 1-week-old boy, yellow sclera, severe lethargy and decreased muscle tone, they are indicative, these two features are indicative of kernicterus. So there is yellow sclera plus the child has lethargy and decreased muscle tone, indicative of kernicterus. His mother notices that symptoms started shortly after birth and have been progressively worsening. The patient is breastfed and takes no medications. So the jaundice is there and the patient is breastfed and takes no medications. His labs are within normal limits with the exception of liver function test. ALT is normal, AST is normal, alkaline phosphatase is 50. Okay, serum albumin is normal, total protein is normal, that is 6.7 grams per deciliter. Now look at the total bilirubin. Total bilirubin is 29.4 milligram per deciliter. And out of this total, most of it is unconjugated bill. So there is unconjugated bill is increased. The boy is taken immediately for treatment. What is the most likely cause for this condition? So what do you think? So within a week, the child has jaundice with kernicterus, and the symptoms started shortly after birth and they have been progressively worsening. They have been progressively worsening. So what do you think is the history? So answer is yes, answer is B, that is absence of UDP glucuronidase transferase. So absence of UDP glucuronidase. So this is Crigler-Najjar syndrome type 1. Okay, now deficiency of G6PD. Okay, G6PD deficiency also produces hemolysis. Yes, but in G6 this also produces hemolytic anemia. Yes, but in G6PD deficiency also unconjugated bill will increase. Yes, but you will also have features of hemolysis. There is no mention, there are no features of hemolysis mentioned here. So there are no features of hemolysis mentioned in this question. So we will give you features of hemolysis like passage of red colored urine or whatever, or other features will be, features of hemolysis will be given, and lab tests will also be given accordingly. For example, the retic count is increased. We may give history like retic count is increased. So there is no such history given here. There is no evidence of hemolysis happening in this. So this is Crigler-Najjar syndrome. Okay, we have seen this. Okay, look at this. A 47-year-old Caucasian woman presents with two-month history of generalized fatigue, slight jaundice and mild itching. So this is important. Slight jaundice, generalized fatigue and mild itching is also there. She also noticed that her urine is darker and her stools have become lighter in color recently. She denies any fever, chills or alcohol use. She has no significant past medical or surgical history and is not taking any medication. She recalls that her mother saw a doctor for eye and mouth dryness. So eye and mouth dryness, this is indicative of Sjogren's syndrome. So eye and mouth dryness, but cannot remember the name of her diagnosis. She denies any illicit drug use, recent changes in diet or Recent travel. On physical examination, her abdomen is soft and non-distended. There is right upper quadrant tenderness to deep palpation, but negative Murphy's sign. Okay, Murphy's sign is positive in cholangitis. So it is positive in cholangitis. Murphy's sign is positive in cholecystitis, that is inflammation of gallbladder. So we'll see what is Murphy's sign. Okay, her laboratory findings were significant for increased liver enzyme. So liver enzymes are increased. 1, 2, direct bilirubin is increased and alkaline phosphatase is increased with normal levels of iron and ceruloplasmin. Okay, so all of you are right answer. So ultrasound revealed no stones in the gallbladder or common bile duct, and ERCP revealed normal extrahepatic biliary tract. Yes, this is the history of autoimmune disease, that is primary. So this is a disease of primary biliary cholangitis. So answer is anti-mitochondrial antibody. So all of you are right. Yes, this is anti-mitochondrial antibody. Okay, this we have seen. Okay, so this is about the liver. Okay, now let us see few entities in gallbladder. Gallbladder. Okay, now in gallbladder, very important, you have gallstones. Gallstones. In the gallbladder, we have gallstones. Gallstones are also called, this is presence of gallstones, formation of gallbladder stones is called polylithiasis. So polylithiasis, formation of gallstones is polylithiasis. Okay, risk factors for gallstones. So risk factors for gallstones are 4 Fs. 4 Fs. So 4 Fs, that is female. So gallstones are more common in female who are fat. So fat, female, fertile and 40. So around 40 years of age, female, fat. Okay, I'll explain once again, Sri Devi. I will explain. Okay, so female, fat, fertile and 40. So are the gallstones. Okay, types of gallstones. Types of gallstones. Okay, so first let us see cause. What is cause of gallstone? Gallstones are formed if there is increased cholesterol. So if in the blood cholesterol is more, so increased cholesterol or increased bilirubin. So in hemolytic anemia patients where bilirubin is high, gallstones can form. So whenever bilirubin increases or whenever cholesterol increases or there is gallbladder stasis. Gallbladder stasis. So stasis of bile in the gallbladder. All these can predispose to cause gallstone formation. Now there are two main types of gallstones. Two types of gallstones. Number one, cholesterol stones. Cholesterol stones. So there are two main types of gallstones. Number one, cholesterol stones. Cholesterol stones account for 80% of stones. 80% of gallbladder stones are cholesterol stones, and these cholesterol stones, they are radiolucent. By and large, they are radiolucent. So they are radiolucent. However, if there is calcification occurring, then 10 to 20% can be radio opaque. So 10 to 20% can be radio opaque if calcification occurs. If calcification occurs in these stones. So if calcification occurs in the cholesterol stones, then 10 to 20% of them can be what you call as, they may appear radio opaque. Okay, so they are associated with, so these cholesterol stones, they are associated with number one, obesity. So obesity. Number two, Crohn's disease patients. Crohn's disease patients can have gallstones. 3, estrogen therapy. Estrogen therapy, multiparity, so fertile females. So multiparity and Native American origin, very important, and Native American origin. So Native American origin. So these people can have cholesterol type of gallstones. Okay, second type of gallstones are pigment stones. So second type of gallstones are pigment stones. Okay, pigment stones can be black or brown in color. Black or brown. Okay, black, they are radio opaque. So they are radio opaque. So the black stones, they are radio opaque, and they are composed of calcium bilirubinate. They are radio opaque because they are composed of calcium bilirubinate, and they are seen in hemolytic anemias. So black pigment stones are radio opaque. They are composed of calcium bilirubinate, and they are seen in hemolytic anemias. So black stones are seen in patients with hemolytic anemia. Second is brown stones. Now second is brown stones. Brown are radiolucent. They are radiolucent. So brown stones are radiolucent, and they are formed in the background of infection. They are formed in the background of infection, and they are seen in, or they are associated with, again, Crohn's disease. Crohn's disease patients can have these. Then hemolytic anemia patients can have black or brown stones both. So Crohn's disease, hemolytic anemias, then biliary infections. So patients with biliary tract infections can have these brown colored stones. Okay, now clinical features. How does the patient with gallstone present if there is no complication? So number one, they have biliary colic. So biliary colic. What is this biliary colic? There is contraction pain because there is contraction of the gallbladder. So on consumption of fatty meal, there is neurohormonal activation, and that causes gallbladder contraction, and this forces the stone into the cystic duct, and that is what causes biliary pain. So biliary colic is because the stone is forced into cystic duct. So from the gallbladder it is forced into cystic duct due to gallbladder contraction. And this gallbladder contraction is because of fatty meal. The patient has taken a fatty meal. Following fatty meal, there is neurohormonal activation. That neurohormonal activation contracts the gallbladder, and from the gallbladder the stone is pushed into the cystic duct, and that causes biliary colic. So forcing the stone into cystic duct. So that is biliary colic. Second, they may be, they may have biliary colics, but in diabetics, they may not have any pain at all. So in diabetics, no pain. So they may have no pain. And how do you diagnose these gallstones? They are diagnosed by ultrasound. Ultrasound will pick up these gallstones, and treatment is remove the gallbladder if polycystectomy if symptomatic. So if the patient is symptomatic, do a polycystectomy. So if they are systematic, do a polycystectomy. Okay, complications of gallstones. Complications are gallstones can cause inflammation of the gallbladder, that is polycystitis. So very common cause of polycystitis is gallstones. So they can cause polycystitis. Number two, these gallstones can obstruct the bile ducts, and then they can get infected. Bile ducts can get infected, so they can produce ascending cholangitis. So bile ducts can get inflamed, producing ascending cholangitis. And three, these gallstones can also go and obstruct the pancreatic ducts, producing acute pancreatitis. So they can obstruct the pancreatic duct, producing pancreatitis. So now if the patient develops ascending cholangitis, what is ascending cholangitis? The bile ducts are getting inflamed. So inflammation of the bile ducts. So we have ascending cholangitis. The patient will present with Charcot triad. So patient presents with Charcot So patient presents with Charcot triad. So in ascending, when they develop ascending cholangitis, they develop Charcot triad. So Charcot triad of cholangitis is jaundice, fever, and right upper quadrant pain. So jaundice, fever, and right upper quadrant pain, that is called Charcot's triad. So one complication is cholecystitis. So cholecystitis, they can have inflammation of the gallbladder or inflammation of the bile duct or inflammation of the pancreas. And fourth, now, fistulas can form between the gallbladder and GI tract. So fourth is fistula formation between gallbladder and GI tract. So fistula formation between gallbladder and GI tract. So, and fistula forms between the gallbladder and the GI tract. As a result, the gallstone may be passed into the intestinal tract. So gallstone passed into intestinal tract. So gallstone passed into intestinal tract, and this gallstone now can cause obstruction of ileocecal valve. Can cause obstruction of ileocecal valve. Obstruction of ileocecal valve. So it can cause obstruction of ileocecal valve. This is called gallstone ileus. Gallstone ileus. So this can cause obstruction of ileocecal valve. This is termed as gallstone ileus. So this is called gallstone ileus. So this is about polylithiasis or gallstones. Looking at the second entity in gallbladder, second is cholecystitis. Cholecystitis. What is cholecystitis? Cholecystitis is inflammation of gallbladder. Inflammation of gallbladder. So inflammation of gallbladder is called cholecystitis, and this inflammation can be acute cholecystitis. So it can be acute or chronic cholecystitis. So this can be acute or chronic cholecystitis. And most common cause, so this cholecystitis, most common cause of cholecystitis is gallstones. So it is divided into calculous cholecystitis, which is due to gallstones, and acalculous cholecystitis, where the causes are other than the gallstones. So cause most commonly is gallstones. Gallstones, that is calculous cholecystitis. So cause most common is gallstones, that is calculous cholecystitis. There is a stone at the neck of gallbladder, usually stone at the neck of gallbladder. So, and so gallstones are the common cause. So the stone is at the neck of the gallbladder or in the cystic duct. So it blocks the cystic duct and there is secondary infection. So gallstone at cystic duct. So this causes obstruction and secondary infection. And that will lead to cholecystitis. So that is due to gallstone. Second is acalculous cholecystitis. Acalculous cholecystitis is when there is ischemia of gallbladder or there is stasis in gallbladder. So this is due to ischemia or stasis in gallbladder. So this is due to ischemia or stasis in gallbladder, or it sometimes infection, viral infection like CMV. So can be due to CMV infection. So infection like, or it can be a primary infection, example CMV infection. So now in cholecystitis, Murphy sign, M-U-R-P-H-Y, Murphy sign is positive. Okay, now what is this Murphy sign? Murphy sign is when you palpate in the right upper quadrant, because of pain in that region where the gallbladder is located. Inflamed gallbladder is in the right upper quadrant, and that inflamed gallbladder is painful. So when you press in the right upper quadrant, because of pain, there will be inspiratory arrest. The patient will stop the breath in inspiration. So that is Murphy's sign, that is inspiratory arrest. So that is inspiratory arrest So what is Murphy's sign? Inspiratory arrest on right upper quadrant palpation due to pain. Due to pain. So inspiratory arrest on right upper quadrant palpation due to pain. So diagnosis is by ultrasound or what you something called as or ultrasound or a HIDA scan. So diagnosis is by USG, ultrasound or what we can do polyscintigraphy. Polyscintigraphy. Polyscintigraphy like a HIDA scan. Polyscintigraphy like a HIDA scan. So that is about cholecystitis. And last entity in gallbladder is porcelain gallbladder. Porcelain gallbladder. Porcelain, P-O-R-C-E-L-I-N. Porcelain gallbladder is patient has chronic polycystitis and eventually his gallbladder becomes completely calcified. So this is calcified gallbladder due to chronic polycystitis. So what is porcelain gallbladder? Calcified gallbladder due to chronic polycystitis. So calcified gallbladder due to chronic cholecystitis, and usually it is found incidentally on image. So and treatment is you have to remove the gallbladder because so it is an incidental finding. Incidental finding on when you are doing imaging. And now treatment is you have to do a prophylactic cholecystectomy. So if there is porcelain gallbladder, the gallbladder has to be removed because of increased risk of gallbladder cancer due to increased risk of developing gallbladder CA. So they are at increased risk of developing gallbladder CA. So gallbladder has to be prophylactic cholecystectomy has to be done. Okay, now about few lines on pancreas. Before pancreas, let us go back to the question again. Which looking at the question again, which Sridevi, you wanted this question to be repeated. A 47-year-old woman presents with 2 months history of fatigue, jaundice and mild itching. So itching, fatigue and jaundice. So there is itching and jaundice. This indicates obstruction. She also noticed that her urine is darker and stools are lighter. All these are features of obstructive jaundice. Urine is darker because of bilirubin in the urine, and stool is lighter because there is no urobilinogen in the stool. She denies fever, chills, alcohol use. She has no significant past medical or surgical history. She is not taking any medication. Her mother saw a doctor for eye and mouth dryness but cannot remember the name of diagnosis. She doesn't use any drugs, no change in diet. Her abdomen is soft and not distended, and there is Murphy's sign is negative. So she is not having cholecystitis. Her laboratory findings show increased liver enzymes, direct bilirubin is increased, and alkaline phosphatase. All these features are going in favor of obstructive jaundice. Ultrasound shows no gallstones. Which of the findings are most likely to be found in this patient? So now look at your options. Now this is the patient who is having autoimmune disease. Okay, now this is a bile duct disease. 1, 2, there is history of some autoimmune disease in the mother also. She is presenting with features of obstructive jaundice. So autoimmune, her age is, she's a middle-aged female. So she falls in the category of, she is likely to have autoimmune disease of bile ducts like primary biliary cirrhosis. So primary biliary cirrhosis. So primary biliary cirrhosis is associated with anti-mitochondrial antibodies. Anti-mitochondrial antibodies. Okay, so this is about this. Now this is about gallbladder. Last few lines on pancreas. Okay, first let us look at pancreas. First let us look at tumor of the pancreas. Okay, in pancreas the tumor is pancreatic adenocarcinoma. So the malignancy of pancreas, malignant tumor, pancreatic adenocarcinoma is the malignant tumor of pancreas. Okay, now From where does it arise? Pancreatic adenocarcinoma, it arises from bile ducts, in the bile ducts. So arises in bile ducts. So it is a malignant tumor of pancreas. Adenocarcinoma is malignant tumor which arises in the bile ducts, and it is a very aggressive tumor. Aggressive tumor. So pancreatic adenocarcinoma arises in the bile ducts. It is a very aggressive tumor, and patient usually presents with metastasis at the time of presentation. So presents with metastasis. So when the patient comes to you, the patient usually has metastasis, and average survival is 1 year. Average survival after diagnosis. Diagnosis is 1 year. So average survival after diagnosis is 1 year. Okay, now so they arise from bile duct site. Where can, in the pancreas, from where will you find the tumor? Most commonly head of pancreas. So it most common site is pancreatic, head of pancreas. And when it arises from the head of the pancreas, it will cause obstructive jaundice. So the patient will present with obstructive jaundice. So tumors arising from the head of the pancreas, they cause obstructive jaundice. Tumor marker is CA 19.9. So increase CA 19.9. CEA may also be increased, but CEA is less specific. More specific is increase CA 19.9. Okay, what are the risk factors for pancreatic cancer? Risk factors are: number 1, tobacco. So smoking is associated with so many cancers. Second, chronic pancreatitis. Chronic pancreatitis, which is usually more than 20 years old. So chronic pancreatitis more than 20 years. Third, age more than 50 usually. Age more than 50 years. And usually Jewish or African American descent. African American descent. So Jewish or African American descent. And clinical features, they usually present late with metastatic disease, but other than that, they have clinical features are the abdominal pain that radiates to back. Abdominal pain that radiates to back. So abdominal pain that radiates to back. Second, weight loss. So they end up with malabsorption. Pancreatic enzymes cannot reach the intestine for digestion of food, so they end up with malabsorption. Third, very important, which we have already read in neoplasia chapter, Trausio's phenomena or migratory thrombophlebitis. Migratory thrombophlebitis. So patients with pancreatic cancer can have migratory thrombophlebitis, which is also called Trausio's sign phenomenon. Migratory thrombophlebitis or Trausio's phenomenon. And they also have obstructive jaundice with non-tender palpable gallbladder. So obstructive jaundice. So they have obstructive jaundice with non-tender palpable gallbladder. This is termed as Courvoisier's sign. Courvoisier, Courvoisier's sign. So this is termed as Courvoisier's sign, that's obstructive jaundice with non-tender palpable gallbladder. Okay, treatment, what do we do? Surgery is done. There is something called Whipple's procedure. So Whipple's procedure is done. In addition, they usually present with advanced disease. So chemotherapy and radiotherapy. Radiotherapy is also given. So radiation therapy and chemotherapy also needs to be given to these patients. So that is about adenocarcinoma of pancreas. Okay, then looking at the entity called causes of acute pancreatitis. Okay, now what is acute pancreatitis? Okay, what is pancreatitis? Inflammation of the pancreas. Okay, now you know when pancreas gets inflamed, the acinar cells of the pancreas will get damaged, pancreatic enzymes will be released and they will digest the pancreas. So in acute pancreatitis, because of damage to the pancreas, pancreatic enzymes are released and they cause autodigestion of pancreas. So in acute pancreatitis, there is autodigestion of pancreas by pancreatic enzymes. So what do you see? Basically, autodigestion of pancreas by pancreatic enzymes. So very important, there is damage to the pancreas or inflammation of the pancreas, whatever happens, ultimately the acinar cells of the pancreas get damaged, they release their enzymes and those enzymes digest the own pancreatic tissue. So autodigestion of pancreas due to pancreatic enzymes. Causes of acute pancreatitis, number one, idiopathic. Two, gallstones can also cause, as we saw, one of the complications of gallstones was acute pancreatitis. Three, alcohol, ethanol or alcohol. So alcohol is a common cause of pancreatitis. Trauma to the pancreas, steroids. So trauma to the pancreas, steroids. Then autoimmune diseases. Autoimmune diseases can cause acute pancreatitis. So autoimmune diseases can cause pancreatitis. And also viral infections like mumps. Viral infections like mumps can cause acute pancreatitis. Okay, so for diagnosis of acute pancreatitis, you know, there are three criteria out of which at least two should be satisfied. So at least two of three criteria to be satisfied. So at least two of the following three criteria should be satisfied. So what are the criteria? Number one, acute epigastric pain radiating to the back. So acute epigastric pain radiating to back. So patient has acute epigastric pain that radiates to the back. One. Two, increase pancreatic enzymes. So once pancreas acinar cells are damaged, the enzymes cause autodigestion of pancreas plus enzymes come out in the blood. So the two important enzymes that you can measure is amylase and lipase. And lipase is considered more specific. So increase serum amylase or increase serum lipase. So lipase is considered more specific. So lipase is considered more specific. And third is, and these enzymes, you know, how much increase? They should be increased more than 3 times. So increase serum amylase or lipase more than 3 times the upper limit of normal. The upper limit of normal. So more than 3 times the upper limit of normal. And last, third is characteristic imaging findings. Characteristic imaging findings. So if two of these three are satisfied, characteristic imaging findings, serum amylase or lipase levels more than 3 times the normal and acute epigastric pain radiating to the back, then you can make a diagnosis of acute pancreatitis. Complications of acute pancreatitis include, number one, pseudocyst, formation of pseudocyst in the pancreas. You know, pseudocyst is a false cyst. A true cyst will always have an epithelial lining. A pseudocyst is lined by granulation tissue. So complications are, number one, pseudocyst formation. Pseudocysts are lined by granulation tissue. A true cyst will be lined by epithelium. So now a pseudocyst forms in the pancreas which is lined by granulation tissue. Second, necrosis and hemorrhage can happen in the family. Necrosis, hemorrhage. So second, necrosis, hemorrhage or infection. So patient can have necrosis, hemorrhage or infection. They can also have serious complications like organ failure. Multi-organ failure can also happen. Multi-organ failure can also happen. And fourth, if you remember, when pancreatic enzymes are released, they cause saponification of fats in the abdominal cavity. So mesenteric fat, the fat necrosis happens, and fat necrosis, areas of fat necrosis have a chalky white appearance due to deposition of calcium. So now calcium gets used up, it precipitates in those chalky white deposits, so patient can develop hypocalcemia. So patients can develop hypocalcemia, so they can have hypocalcemia also. So this is about acute pancreatitis. Last few lines on chronic pancreatitis. Just few lines, 2 or 3 lines on chronic pancreatitis. Okay, now what is chronic pancreatitis? In chronic pancreatitis, there is chronic inflammation in the pancreas. Then what will happen? Chronic inflammation will damage the pancreas. There will be atrophy of the pancreatic tissue, and then finally there will be calcification in the pancreas. So in chronic pancreatitis, what do you see? You see chronic inflammation, atrophy, and calcification in the pancreas. Calcification in pancreas. So there is chronic inflammation. Inflammation will damage the pancreatic acinar cells. The tissue will become atrophic, pancreatic tissue, and calcification will occur. Main cause is alcohol. Alcohol is the main cause, major cause. So major cause of chronic pancreatitis is alcohol. Second, it may be idiopathic. Alcohol or idiopathic. Then third, patients with cystic fibrosis. There's an entity called cystic fibrosis, which is due to mutations in CFTR gene. CFTR gene. So patients with cystic fibrosis, they develop thick mucus plugs in pancreatic ducts. Thick mucus plugs in pancreatic ducts, which lead to inflammation, chronic inflammation, atrophy, and calcification of pancreas. Chronic, which cause these cystic fibrosis. So now chronic pancreatitis, what does it lead to? So patients with chronic pancreatitis, now they will not have pancreatic enzymes. Acinar cells titus, they will have, the acinar cells will undergo atrophy. So this results in pancreatic insufficiency. What is pancreatic insufficiency? Now exocrine pancreas is not producing enzymes. So there is pancreatic insufficiency. Pancreatic insufficiency leads to malabsorption. So if pancreatic enzymes are not there, food will not get absorbed. Pancreatic enzymes are needed for digestion and absorption of food in the small intestine. So if pancreatic enzymes are not there, if exocrine pancreas is not producing enzymes, then there will be malabsorption. So patient will have malabsorption. And serum amylase and serum lipase levels. They may be normal or increased. So serum amylase and lipase levels, they may be normal or increased. Whereas in acute pancreatitis, they will always be elevated. So here they may be normal or increased. Okay. So now this is about the GI tract and liver, which I have to cover. If you have any questions, you can ask. And in the next class, I will start with kidney. In the next session, in the next class, I'll be starting with kidney, renal pathology. Okay, Sridevi, you have asked me a question. Does it have mitochondrial inheritance? What entity? Which entity? Yes, central umbilication means, okay, Adesh, central umbilication means See, in metastasis, when there are mets in the liver, you will have multiple nodules in the liver, number one. And the center of the nodule will be depressed, because the center of the nodule, it will be something like this. So center of the nodule is depressed, because this center portion of the nodule is furthest away from the blood supply. So the tumor cells here undergo necrosis. So because it undergoes necrosis, the central portion becomes depressed. So that is central. This is called central umbilication. So this is the nodule. This is the metastatic nodule. So center is depressed due to necrosis of tumor cells in the center. So this is called central umbilication. So this is what we call, so the depressed center is called central umbilication. Okay, for that, oh no, that was, no, that doesn't have, that is an autoimmune disease. That is an autoimmune disease. It is not associated with mitochondrial inheritance. Okay. So, okay, then if there are no more questions, good night, all of you. Good night, all of you. Okay, mother to daughter inheritance. Okay, okay. No, okay. Then, Sridevi, I'll tell you this primary biliary cirrhosis has an no, mother to daughter inheritance. Okay, it was hinted. No. Okay, primary biliary cirrhosis, I'll check and tell you, it has HLA association. There's an HLA type. So, it can be passed through the, I mean, it has a particular HLA association also. So, I'll check the HLA association and tell you next time. Okay. Okay, so